All right.
Hi,
And
everyone, and thanks for coming. I'm Thomas, and
hi,
I
I'm
guess
Jim.
Jim. Jim and I have fascinating conversations about a wide variety of herb-centric topics. And one of the things we've talked about is long COVID and some of our experiences with it. And I've got this long COVID course coming out. And I absolutely detest traditional advertising. And I thought, what if we just had a conversation about long COVID, and then maybe people could get an idea of what my approach is and know if they wanted to take my course or not.
Yeah, and we can it's kind of like you're a fly on the wall on the conversation. Like if Thomas is wondering something and he calls me to talk about it, or if I'm wondering something and I call him to talk about it. And sometimes that might be like, oh, I don't know as much about this and Thomas knows about that. So I'm going to call Thomas. Like that's a great strategy. And a lot of times herbalists, we all feel like we need to be like generalists and specialists at every single thing that there is. And that's not realistic. There's always going to be areas that we don't know as well. And we shouldn't feel guilty about that or like we're not good enough. We should be like, oh, there's someone else who knows that. And, how can I establish relationships and learn from those people or refer to those people if it's more appropriate? So that's one aspect. And another thing that we do, and some of probably what's going to happen today is going to be along those lines, is we just talk to kind of like flesh out some ideas like, hey, I've been wondering about this. I'm wondering what you wonder about that because it'll help me wonder about that. And then I'll maybe think of something I wouldn't have thought of otherwise. So that's going to be a little bit what our exploration is going to be like today.
Yeah. So, shall we just dive in?
Yeah, the first question I wanted to ask is how is Jack?
Jack is good. He is, I think, developing some arthritis in his back left hip. And I've tried several things and kind of finally settled on MSM capsules, like 1,000 milligrams. Have you seen the dog treats with the hole in them for they're called pill pouches? Oh my
No,
God.
I haven't.
It
Yeah.
makes giving dogs medication so much easier. So I'm doing MSM and some like glucosamine chondroitin chews and a little Solomon Sil every now and then. I want to bake some like Solomon Sil dog biscuits for him, but I haven't gotten around to that yet. He's doing pretty good. I'll let him know you ask about him.
Okay, good. We are buddies.
You might be his favorite pillow.
Yes, if you haven't picked up, Jack is a dog. But okay, getting started. I mean, like, I've got some sort of like introduction queries. Like, they're just the most basic stuff. And, one of these things is like, what is long COVID? What does that mean? How do you know it's long COVID? Do you assume that if someone has a certain set of symptoms or is presenting in a certain way that is congruent with long COVID, that it therefore must be long COVID? I know that you don't do that. Um, what is happening? Like, what do we know? How do we make long COVID be meaningful and not something that is just like, I suppose what maybe we would say is like the new candida or the new Lyme disease or the new chronic fatigue, or like
Right.
there's a set of common patterns that people can express with. And then, every so many years, there's like a blanket explanation that gets spread over everything when maybe it fits some things, but not everything. So how do we make long COVID useful? How do we make that make sense?
Yeah. So there is a really long history of weird shit happening after infections. And depending upon the infection, the presentation might be different, right? So, like long polio or post polio syndrome might be characterized primarily by muscle weakness. And recent research would indicate that long Epstein-Barr virus is the driving force behind multiple sclerosis. And then we have other types of infections that provoke. So in the case of polio and MS, those seem to be very delayed presentations, delayed by decades. But then we have other post-infectious illnesses that arise much more rapidly. So you get a UTI or an STD or a gastrointestinal virus, and 3 to 10 days later, your joints start swelling in an asymmetric and roving way. So maybe you wake up and it's your right big toe, and then that night it's your left knee, and then the next day it's your right hip, and then your low back starts hurting, and then you get iritis, and you've developed what's called reactive arthritis, which is a post-infectious autoimmune condition. The old saying is can't see, can't pee, can't climb a tree, because the symptom pattern is eye, back, and urinary, with joint pain. So can't climb a tree because your joints hurt, hurts to pee. These post-infectious illnesses sometimes have a lot in common. I would say that for many people before COVID, developing chronic fatigue syndrome probably occurred as a post-viral illness. There's, research showing that rates of chronic fatigue syndrome skyrocket after particularly nasty influenza seasons. And so they think that there's some aspect to that. As far as COVID goes, what is long COVID? Long COVID has multiple definitions for multiple organizations and multiple names. You might hear it called long COVID. You might hear it called post-acute COVID syndrome, PACS, or you might hear it called PASC, post-acute sequel of COVID, because people like to come up with their very similar acronyms. Whatever the name is, generally, people are referring to symptoms that didn't happen before your COVID infection, and it's now at least, pick a number, 4, 6, 12 weeks afterwards. I think the WHO is a 12-week. It was originally 6 months, and then they rolled it back. At some point, you transition from the lingering effects of COVID into a new definition, characterized by a wide variety of symptoms. There's like 203 symptoms under investigation, with a core of maybe 20, 25 symptoms and a whole lot of random miscellaneous things thrown in. And I think that it is significant because it occurs at a much higher frequency than other post-viral infections do, or other post-viral syndromes do. But there's a lot of overlap, especially with chronic fatigue syndrome. In fact, around 50% of people with long COVID meet the diagnostic criteria for chronic fatigue syndrome. The thing with chronic fatigue syndrome is, like, there is no one cause. It's an umbrella that people with patterns that can't be explained get lumped under.
Yeah, right. It's like a destination, an unfortunate destination that can be arrived to through many different paths.
Yeah, and there's a lot of overlap in the therapeutic approach as well. The current researchers are saying that there's probably common underlying etiology in chronic fatigue syndrome, post-Lyme syndrome, and long COVID. Basically, your infection causes damage and systemic inflammation and immune hyperreactivity. And depending upon your level of health when you entered into the infection, you get a wide variety of symptoms afterwards.
Yeah, so that that connection, especially to like something like chronic Lyme, creates the sort of like needing to look into and address when we're talking about long COVID, we're talking about chronic Lyme, or other kind of post-viral or post-infectious situations. Is the right way to think about it like the pathogen is still there and still doing stuff to you? Does it make more sense to say the pathogen was there, your body has cleared it, but now there's like immune dysregulation or inflammatory dysregulation or systemic dysregulation of whatever things? And to what degree is it, probably not one or the other, but in different situations, a combination of both things? Like, what do we know about COVID, or what do we currently suppose about long COVID?
So that's a great question. And I think the answer is nuanced. There's evidence that you can have a persistent COVID infection where the virus is still actively replicating, but at a much slower rate in your GI tract, in like the base of your nerves that control your sense of smell.
Mm-hmm.
There's some evidence pointing towards a persistent infection, at least that persists longer than the acute presentation. That infection seems to be cleared in the overwhelming majority of people within 6 to 8 weeks after the initial infection. I'm going to hold some space for some people, especially with the worst infections, probably do have viral reservoirs longer than that. For instance, they found viral RNA in the brains of people that had died from severe COVID in the hospital. But multiple studies after that failed to find it in the cerebrospinal fluid of people with long COVID. They found a lot of inflammatory markers. They didn't find any viral RNA. So I think that there's a potential for a 6 to 8 week time period after the initial infection where you might not have thrown off the virus, but at some point, most people do. And the people that don't, it's not difficult to identify because they're the ones with like overt lymphopenia. They have like their white blood cells are tanked. And so just you can tell their immunity is tanked from basic blood work patterns. I think that's a very small percentage. And the people that I have worked with, I approach the case like I do other post-viral syndromes, which is the focus is not on persistent infection, but on post-infectious immune reactivity. And that's nuanced because, like we say, immune reactivity, what we really mean is post-infectious immune gut nervous system reactivity. Because you can't talk about the immune system without acknowledging that the gut and the nervous system have an intimate conversation continually with it, and they kind of all get thrown off at once.
Mm-hmm. Right. And this is relevant because for people that have long COVID who are continuing, especially if it's been longer than 3 months, it's been like 6 months. Mm-hmm. And I've seen a lot of people being like, oh, I'm still hitting the antimicrobials. I'm still hitting I want to focus on killing this thing because it's not dead yet. And that might not be the greatest strategy. I mean, we do know that a lot of the herbs that work as antimicrobials, they do also do other things. They may also have anti-inflammatory activities, but if the rationale for your protocol is just to kill stuff, that might not be the best way to address that. And you mentioned,
I want to jump in here and say too, it's not just herbs. You mentioned chronic Lyme disease, and the overwhelming majority of information indicates that it's not a persistent infection driving those symptoms. There is the potential for like bacterial remnants that didn't get cleared, but in all but one of the studies, like those bacterial remnants couldn't reproduce, couldn't infect anybody else, couldn't cause problems. Yet people still have these persistent issues. And it's not just herbs that can both reduce infection and affect other things. The most common medication for it is doxycycline. Doxycycline is a well-established, potent anti-inflammatory and immune modulator. It's used in autoimmune conditions. It's used for inflammatory conditions. So people take it and they feel better and they think, oh, it must have been a persistent infection. But they're also getting these other effects that we're talking about from it. And I think the same thing probably happens with herbs.
Yeah, probably. So you mentioned, like looking at white blood cell counts. Is there a long COVID test? Can someone go and be like, I think I have this thing. Can I go and get a test? What would the test be? How accurate is or not accurate is the test? Like, what are the strategies for getting a diagnosis? Maybe, especially, and this relates to some of the questions that people have sent in. When you have something that's not really visible and you're exhausted and it seems like it's long enough and other people are fine, but you're not, and maybe there's some stigma attached to it, or you just, like what can we do to sort of like establish or quantify this? To maybe be taken seriously, both by all manner of medical professionals, but maybe also the other people in our lives who might be like, oh, how come you don't just get past this?
Yeah, there's not a test. That's unfortunate. And also, I think a lot of people don't realize just how many diseases and disorders don't have a definitive test. I mentioned multiple sclerosis earlier. There's no test for multiple sclerosis. You can't do a brain MRI and diagnose multiple sclerosis based on that. It's a clinical diagnosis based on a specific symptom presentation that's reinforced with an MRI.
Right. As would be the case with like chronic fatigue, fibromyalgia, and a lot of these overlapping patterns.
Yeah, absolutely. There's not a blood test for fibromyalgia or for chronic fatigue syndrome. Or, with Lyme disease, it's also a clinical diagnosis. There's a blood test that helps to reinforce the diagnosis. But in endemic areas, if you go into the doctor's office and you had acute onset knee swelling and fever and you've just been hiking, they're going to say, oh, you have Lyme disease. Here's some antibiotics before running a test. So with long COVID, you have this set of symptoms that some of which have extreme overlap with other conditions, and some of which don't have as much overlap. It can be tricky to tease apart, but the easiest is just to correlate the new onset of symptoms with a known infection. I think that because the primary pattern in long COVID involves new mental health struggles in around 50% of people with long COVID, and because we've just been through the first pandemic that any of us have ever experienced, and our whole lives have changed. Maybe one of the most important things to consider is anxiety and depression as a cause of fatigue and aches and pains and slow cognition and all of those things, which can be caused by COVID and can arise without or despite COVID. So it's difficult to tease apart, but the more you see the patterns, the easier it is.
Okay. And so, one of the strongly presenting experiences is just really severe fatigue, really severe exhaustion and lethargy. And, that is common after infections, but this is to like a different degree. Like if we're looking at that as being sort of like one of the keynote, presentations, how do we want to think about that? And how do we want to think about like the sort of vicious circle of like, I feel terrible. I don't have the energy to do anything. I need to like just rest and convalesce. But if that's an extended convalescence, you're also sort of like you're getting weaker from convalescing if you're not getting the exercise, and it creates one of those little chicken and the egg situations of like the degree to which you feel crappy means that you can't move around, but the degree to which you can't move around eventually increases the degree of crappy that you're feeling.
Yeah.
Crappy being of the medical term, I think.
Yeah, it's a highly accurate term too. So the overwhelming fatigue that people with long COVID get is not unique to long COVID. It's also found in chronic fatigue syndrome. And I would say that the potentially the biggest differentiator is teasing apart post-exertional fatigue and malaise from severe fatigue.
Mm-hmm.
If you're very fatigued, but getting up and going to the grocery store or the mailbox doesn't put you back in bed for days on end, there's a good chance that your fatigue is predominantly cognitive driven and deconditioning. It's just you're deconditioned and you're really tired, and that makes everything worse. The type of fatigue that I think of as post-exertional malaise or post-exertional fatigue with malaise is a bone-deep fatigue that normally manifest within a day or so of exertion, and the exertion doesn't have to be physical. It can also be mental exertion, can lead to the same types of fatigue. And the pathophysiology is probably significantly different. Like, we should get fatigue. It's normal to get fatigued when we have an infection. Mm-hmm. Fatigue is part of illness syndrome or sickness syndrome. This thing that happens when we get an infection and we spike a fever. Our body initiates a lot of protective mechanisms. Our immune response in our fever is a protective mechanism for us, but it also initiates protective mechanisms for our herd mates or cave mates. And so we get a lot of lethargy from acute infections so that the immune system will have more energy to use, because immunity sucks down lots of fuel, or an active immune process sucks down lots of fuel. And also so that we don't go out and spread our illness to others. And with that comes a set of changes in neurotransmitters. We get a significant decrease in dopamine and serotonin, so that we're sleepy and lethargic, and we don't like get out and move around, in addition to the decrease in like energy available to our muscles, because it's all being used for our immune system. So I think that type of fatigue is normal, and you should rest when you're in the acute phase. The first week you have COVID, I think that resting is good. Eventually, I want to get around to writing about like the art of convalescing.
Yeah.
But resting well or convalescing well might look different than the type of rest that you're getting. So convalescing well rest is typically not going to be in your bed, and you're not going to be horizontal. You're going to be somewhat upright, you know, couches, chairs. It'd be the bed if you build your pillows up, but laying flat on your back and not moving radically accelerates deconditioning and worsens outcomes. And also, you don't want to like be running marathons the day after you have a fever. There's this balance that I think is difficult for some people to get. So I think that if you start moving and increasing your activity level within about a week of the infection, you minimize your chance of deconditioning. And also, I don't think that you should get your heart rate over 100 for about 6 weeks after a COVID infection to minimize the risk of sudden death and heart attacks. So that's a very rambling answer, and I forgot where we started. Were we still talking about post-exertional malaise and fatigue?
Yes, we were.
Yeah.
We were. So the difference between, okay, that acute tiredness, that everything is happening tiredness, and the sort of like long, it just won't go away tiredness, where even if you think too hard, you're like, I can't anymore.
Yeah. So the cognitive aspect of the persistent fatigue is probably more closely related to dysautonomia and sensory nerve issues.
Mm-hmm.
So a lot of people that develop full-blown chronic fatigue syndrome from COVID have damage to their peripheral nerves. And when your peripheral nerves are sending really loud jumbled signals to the brain, it can be overwhelming. Mm-hmm. So to some extent, I think that the type of fatigue felt is the type of cognitive fatigue felt is a sensory-based cognitive fatigue. Like if you go out on the ocean for the first time and the waves are rough, you might get fatigue just from the constant changing of proprioceptive input from the waves. And that's pretty common even with sailors when they hit the open waters. The first few days, they're just kind of lounging around and resting as their brain tries to interpret all of these new senses. I think that that's a part of the cognitive fatigue with long COVID. We also have cognitive fatigue with long COVID that's probably driven by the shunting of tryptophan to the chironine pathway instead of the serotonin pathway. So brain inflammation driven cognitive fatigue. And then the physical fatigue can be multifaceted and has a lot of roots in dysautonomia and like your blood pressure bottoming out when you stand up really freaks the body out and causes a lot of changes, including fatigue. So I think that there's a lot to clinically. One of the most important things to do is to try to tease apart how much of the fatigue is from poor sleep, which is common in infections, how much of the fatigue is from anxiety, depression, which is common in long COVID and in pandemics without actually being infected. How much of the fatigue is from deconditioning, and then what's left after that. So that's kind of how I think about it.
Okay, so you mentioned dysautonomia. And I think that's something that a lot of people like, they're not entirely sure what that is. So how does, what would be a good way to wrap your head around what that means? What are the different maybe presentations of that related to long COVID and not every possible one? Like, for example, POTS seems to be fairly common.
Yeah, so POTS is the most popular dysautonomia to diagnose because it's the easiest dysautonomia to diagnose. If somebody has a greater than 30 beat per minute heart rate increase when they go from lying down to upright, then they have POTS. POTS is just a flavor, a variety of this larger umbrella called dysautonomia, but it's probably the biggest catch-all. And the number of people with long COVID that have dysautonomia in general is incredibly high. So in the biggest study, they found 79% of people with long COVID at 6 months after infection were diagnosed as having POTS, and 25% of people missed the diagnosis by 1 beat per minute cutoff.
Right, which is not,
they're
not in the clear.
Yeah, so it's over 90%, approaching 100% of people have some level of autonomic dysfunction after COVID. That's why I consider inflammatory dysautonomia to be the number one long COVID pattern, but there's others. And dysautonomia is when the autonomic nervous system that controls your stress response goes janky. So you've got sympathetic, parasympathetic autonomic nervous system. A gross oversimplification is rest and digest is parasympathetic. And then your normal, like, hard driving day-to-day activities are governed by sympathetic activity. In dysautonomia, there is a dysregulation of the autonomic nervous system. And how that differs from like how stress or anxiety dysregulates your autonomic nervous system is maybe important to talk about. Like when you have chronic stress, you can absolutely have an increase in sympathetic tone. In dysautonomia, you have an increase in sympathetic tone or a decrease, an increase in parasympathetic or a decrease. And those might be caused by issues at the pituitary hypothalamic intersection, but more frequently they're caused by damage to the peripheral nerves themselves, whether that's from inflammation or autoimmunity or injury. You know, you can have diabetic dysautonomia, where a lot of people know about diabetic neuropathy, where the nerves in your feet go numb and die off. If that happens more broadly, your whole autonomic nervous system can go wacky and you can develop diabetic-induced dysautonomia. So dysautonomia is this dysfunction of the autonomic nervous system. In the case of long COVID, it's probably driven initially by damage to the nerves directly from the virus, the inflammation that follows the damage to the nerves and surrounding cells directly from the virus. And in some people, that sets the stage for a persistent autoimmune reaction, where the damage and inflammation plus your own set of genetics and protective mechanisms all kind of interplay, and you wind up with having antibodies to, some people wind up having antibodies to muscarinic receptors or nicotinic receptors, or, you know, a variety of components of your nervous system can become the target for your immune system, which drives a sustained inflammatory autoimmune-based response.
Okay, so people are asking, there are questions, and you know, some of these, there's a bunch of questions and they overlap. You know, they're like, there may be kind of the same question. They go off in different ways. So I
Sure.
can't necessarily read all of them together, but
We have
obviously
a lot of questions.
there are a lot of questions. I tried to lump them together into topics so I could like,
Yeah.
'cause I know there's a chat here that I can look at that Tiffany is being awesome with, but I also have paper because I like paper. And so the question for a lot of people who are struggling with this is like, well, okay, what do I do? What are some strategies to address that? But maybe before we go into that, we can like loop back around to this because we're talking about ideas for long COVID or post COVID or the different acronyms that you had. And a lot of people, even when COVID as an acute infection was happening, there was this idea of like, what is your protocol for this thing? And is herbalists who try our best, I think, to do what every holistic practitioner says that they do, but not all of them actually do. We're trying to have like protocols for people and not protocols for conditions, right? You have like a protocol for COVID. That means you would give that protocol to like anyone who had COVID, even though they might be presenting differently. And we've all lived in houses, unless you're very young. Maybe this hasn't happened to you yet. We've all lived in houses where everyone was sick with the same thing, but it was a little bit different, and probably for people that experienced COVID, it was like that too. Someone had a mild case, someone had a more severe case. Someone had GI stuff, someone in the same house had respiratory stuff. Someone had a sore throat and swollen lymph glands, someone had a fever, someone didn't have a fever. And so it doesn't make sense to have a specific protocol for COVID without accounting for all of that. And I know that you've got um, uh, looking at different overlapping patterns.
Mhm.
And so I want to get into that because that can sort of like lay out where we go next. But before we get into that kind of individuation, what are sort of like just the foundational primers? Like, is there something that like, yes, it totally depends on who you are and how you're presenting, but everyone should probably think about maybe these nutrients or this particular thing because it's sort of going to constitution or sort of foundationally cover a lot of the bases. And I know that with nutrients, they are not only like stuff we need to keep us healthy, but when we're having immune reactions or when we're having nervous system reactions, in order for us to go through the processes of an immune response or a nervous system response, we're utilizing certain nutrients. And if we are deficient in them, then that will impair our ability to sort of like carry out the process in a way
Yeah.
that we should be able to. So before we get into the different patterns that you've defined, like what are the foundational things you want to be thinking about?
Sure. So I think first and foremost, there is a philosophical difference between treating a disease or disorder and building health.
Hmm.
And even if you aren't going to address a disorder or disease, or maybe you have one that there is no thing that will change the course of the underlying disease, you can still build health. And the process of building health often results in an improved experience of life, whether you have a disease or not. So I like to tell people, my clients that have a long-term chronic problem that's not going to go away, that we can always focus on building health and finding wellness within the illness. So I think that there are fundamental and foundational things that we can all do to build our health probably better than we currently are. And most people already know those things, right? Like you don't have to attend a class to know that eating your fruits and vegetables is good for you and building of health. I would say that in addition to basic nutrients, focusing on getting rest and restoration, focusing on moving our body, focusing on our connection with other people, with higher purpose, with nature, with pets. I think all of those things are inherently health building. And many times when you're in the middle of a new chronic disease, you forget about the things that you know make you feel well. And so I think before we talk about kind of basic strategies for infectious or post-infectious conditions, maybe we should start with a survey, an inventory of the practices that we already know make us feel good, that we already know improve our vitality, and that have worked for us before. Because if we have an inventory of those and we have these things that have worked to build and improve our health before, then we have strategies we can immediately implement with a pretty good idea of how they're going to now create change in our body. So I would say first do an inventory of things that you already know make you feel good before you had COVID, and then honestly assess how much of that still exists in your life and where there's space to bring in more of it.
So what you're saying is people should get pets, like dogs, cats, ferrets, maybe a goat. I think I heard you say pets is like...
I said pets. Yeah, connection to everything is important for us. One of the things about like long COVID is that it happened while we were all in a pandemic and really freaking stressed, and a lot of people are really lonely. And when you're having those things going on, remembering the stuff that you did to improve your health and vitality in the past can be difficult, but it's a rewarding thing to do, is to take an inventory of all the stuff that you know that worked beforehand and then see if there's room for it now. Specifics for infection, you know, having an infection tanks your vitamin D. One of my graduates told me that they had their vitamin D level checked just before they got COVID, and then they had it checked again, I think it was 4 or 6 weeks later. And they had continued their supplementation, and it was 30 points lower a month after COVID than it was beforehand. Vitamin D doesn't just help our immune system respond to infection. It's actively used when we have an infection, and so our levels are going to tank. And so I think vitamin D supplementation is a very reasonable thing for anybody that breathes to probably do, but especially if you've just had an infection. Another thing that I see a lot of, like getting COVID causes GI symptoms in 30 to 50% of people. And when you go from healthy to everything you eat makes you nauseous and gives you diarrhea, you tend to not eat as much. And also, your infection has depleted your reserves of everything. And so what I have seen a lot of is this like a borderline deficiency leading into COVID, followed by raging deficiency after COVID. So, you know, this makes it difficult to tease apart. Is your post-COVID shortness of breath from lung damage, or is it from acid reflux that you developed because of COVID, or is it from dysautonomia, or is it from anxiety, or did you have like mediocre iron stores beforehand, and now you have overt anemia, and that's causing the shortness of breath. Like the most difficult, the reason why it's taken me so long to put together a class about COVID is figuring out how to teach people how to tease apart all these little nuances that can be caused by many different things, or have many different underlying pathophysiological basis.
Yeah, and I think that just like, it doesn't make sense to say like, oh, I want the protocol for COVID, I want the protocol for long COVID, and it's gonna be this thing, and I'm gonna learn it, like someone can write a book, the COVID or long COVID protocol, and there's the protocol, and that's what everyone should do. But also I think a lot of people, especially people into herbs, they're like, oh, like, there's got to be that one thing, that one strategy to do, and really, especially for complicated things that act on so many different systems, it's not one thing, it's all of the different approaches sort of like working together and synergizing with each other. And so an herbal protocol divorced from a nutrient protocol, or divorced from activity, or divorced from like making some time to like be outside or be in nature, isn't going to work as well as it's going to be without doing those other things. And it's always going to be more than just like, oh wait, I heard about this new supplement or new herb or new whatever, it's supposed to be really good for this. That we're not looking at isolates, we got to look at like that larger picture, which again in holistic medicine we all sort of reflexively say that's what we do, but in practice, that's not always what we do, because I think everyone wants to be the person who finds the thing that's so great for them and takes it and like, oh my God, this was it. This was like the key. This was the thing that did it for me. Especially when occasionally you might hear that from someone else. That they try something.
I mean, I wish that I had a protocol for long COVID, or a supplement, or I would, if I had a magic remedy, I would be sitting on a beach in the Bahamas sipping a Mai Tai right now. Like the reality is there is no one protocol for long COVID, because there is no one underlying thing driving all of the symptoms that people experience with long COVID. There's a dozen underlying things, and they all create overlapping symptoms, and you have to tease it apart. It's not what most people with long COVID want to hear. That's not what most people into herbs want to hear. And if you'd asked me 20 years ago, I probably could have come up with a program for long COVID back when I thought things were a lot more simple than it turns out they actually are. The more I have learned, my personal journey as an herbalist, I started where I thought, oh, okay, actually, this is all fairly simple. There's this secret system of medicine that has been oppressed and silenced by big pharma, and all you have to do is warm people up when they feel cold and cool people down when they feel warm, and tighten things that are too lax and moisten things. And if you just do this basic approach, everybody gets better. And then it turns out that wasn't so. And over time, I eventually came to the conclusion that like herbal medicine is just as, or can be just as complicated and nuanced as mainstream medicine or any other form of medicine. Chinese, Ayurveda, they're all complicated, intricate systems with no easy answers, and they're all like systems where you have practitioners that spend a large part of their life figuring out these complications. So, yeah, I wish that I had something simple. And I am working on what might wind up being a handout to the most common pattern of long COVID. I aspire to put together something that can help a lot of people with some basic, like learning what dysautonomia is and how to address it is something that every herbalist should know because it's such a prevalent thing that is under recognized. But it's also something that there are legit home remedies to help manage, like people with long COVID, if they have any type of dysautonomic symptoms, if you get dizzy when you stand up, and you didn't before you had COVID, you probably have some type of dysautonomia, some variant. Orthostatic intolerance is a kind of a key indicator there. And it could be that all of your symptoms are related to that. Your IBS might not be from your gut. It could be from your dysautonomia. Mm-hmm. So for those people, elevating the head of the bed and wearing compression stockings and using electrolyte replacements or salt supplements can be incredibly helpful in alleviating both the cognitive and the physical fatigue. So I am actively working on trying to put together something to help guide folks through a basic self-treatment, but also shit's complicated.
Yeah. Right. Yeah, conditions are complicated, and because people are complicated, people are not simple, Okay, so there's a bunch of the questions. I have gone through a bunch of the questions and vaguely lumped them up into categories, even though it's hard to put things in one category. But I think before we do that, before we say like, what about respiratory issues? What about cardiac issues? What about like more physical nerve issues versus more experiential, cognitive, emotional, nervous system issues? You've got some patterns,
yes,
that you've laid out to sort of like frame how to think about it. And I think like a good practitioner, when they're addressing something, even if they don't have a specific like, oh, you have this, then you should take this or do these four things. One of the things that we often do have is like, oh, wait, yes, it's complicated, but rather than being like a spilled box of Lego on the floor kind of complicated, where you had the instructions, but now all the pieces are broken up and mixed together, and it's just going to be a lot harder to find them all. We have ways of thinking that don't make things less complicated than they inherently are, but make our ability to sort of like find patterns and assess like, where do I need to go? What makes the most sense? Like, should I not invest a ton of energy into this area because it's not going to be as productive as maybe like looking at it in this more focused way? So could you go over your patterns and long COVID so we can get sort of like a sense of like the framework we can think about individual presentations with?
Yeah, absolutely. I'm going to share my screen.
Screen share.
So this is generally how I see the patterns in long COVID. You have, let's see, can I do I don't want to annotate. I want a spotlight or something. Oh, well. Nope. Okay, well, so can you see my arrow on the screen, Jim?
I do not see your arrow.
You don't see my arrow. Okay, well, I don't know how to highlight on this, but in the center, you have your most common pattern that I'm calling the neuropsych gastrodysfunction pattern, or just pattern 1. Okay. And this is where I think the core symptomology in long COVID resides. So you have dysautonomia, with POTS being the specific flavor more people get diagnosed with than not. And that nervous system dysfunction, along with the dysregulated neurotransmitters from the initial infection that probably persisted because of sleep disruptions, drive the anxiety and depression. And then you have the GI symptoms, which it's really interesting. You can't necessarily tease apart the nervous system symptoms and the GI symptoms. And maybe we shouldn't try to tease them apart in other conditions. Maybe that's not just long COVID. Like we now know that getting depression messes up your microbiome, and also messing up your microbiome increases your risk of depression. So like it's probably we should be thinking about the nervous system and gastrointestinal system together most of the time. But this pattern is characterized by neurological symptoms and gastrointestinal symptoms, both of which probably drive the sense of overwhelming fatigue and oftentimes pain, especially like diffuse pain, the hurting, but it's not like a particular point that area that you can point to.
Mm-hmm.
That's the most common pattern. And then you have the respiratory damage pattern. And I would say that this core pattern exists with other patterns overlaid onto it. I have seen one case of respiratory damage that didn't have any nervous system or GI symptoms. It was straight respiratory damage, but literally only one case of that. The respiratory damage can lead to chest pain, asthma, chronic cough, and pulmonary fibrosis.
And just for people that don't know the word fibrosis in terms of what that means.
Oh, yeah. So you basically get stiffened scar tissue like lung tissue.
Mm-hmm. Right.
And so you get fibrotic tissue that doesn't expand and contract and exchange O2 and CO2 like it should. Pulmonary fibrosis also happens in some types of COPD. It can happen from lung injury, from heavy smoke inhalation. It can happen from like chronic environmental exposure, like woodworkers that don't wear masks over 50 years and things like that. Pulmonary fibrosis is incredibly difficult to reverse. And most of the people that have that level of respiratory damage were hospitalized, and a lot of them had acute respiratory distress disorder in their hospitalization. So that's going to be kind of worst case scenario. I see a lot of people with a chronic cough. Sometimes that's GI related. Sometimes it's dysautonomia related. Sometimes it's lung related.
Mm-hmm.
Also, maybe there should be a pattern for chronic cough that's by itself, and it's just like the pattern that magically responds to Linden.
Okay.
There is a specific, like sometimes when nothing else works, no other demulcent, Linden is just freaking magical sometimes, and I don't know why. So maybe that's a seventh pattern.
Yeah, just to say, I mean, there can be cardiac involvement with cough, and I wonder whether that might be like a little overlap there.
Yeah. Could very well be. So we've got cardiovascular damage next. We're going to go counterclockwise for a second through the flower petals. The cardiovascular damage everybody experiences with COVID. Most of the time it's asymptomatic. So your risk of clotting after a COVID infection is elevated for pretty much everybody, and stays elevated for about a year, peaks at a couple of months, and then slowly gets less and less and less and less for about a year.
Mm-hmm.
outside of the increased risk of clotting, you also have myocarditis, arrhythmias, and primary symptoms are shortness of breath and chest pain. But notice that shortness of breath and chest pain can exist in the respiratory damage side. And also, while it's not listed, it can exist in the neuropsych gastrodysfunction in pattern 1. I'll show you in just a second another chart where I tried to map out some of the craziness of the interactions.
Yes, I like that one. It looks like how you think.
Yeah. Yeah. Oh, that might be interesting. So, yeah, I'll tell that story later. So then you've got the exacerbation of pre-existing conditions, and this is probably as much pandemic related as it is long COVID related. But a lot of people missed doctor's appointments, herbalist appointments, screening exams, didn't take care of themselves as much. And so they've just seen an exacerbation of their pre-existing conditions. And many times that was worsened by an acute COVID infection. Then you've got people that will experience the immune damage. I talked about that with a question earlier with acute lymphopenia, and oftentimes that leads to reactivated Epstein-Barr virus, which I'm sure is a topic we'll get into tonight, but also to throw it out there, that's not unique to COVID. So most people that wind up in the ICU wind up with some level of reactivated Epstein-Barr virus. Like, a serious health problem is a stress to the body, and a stress to the body can suppress the immune system enough to allow Epstein-Barr virus to become reactivated. Does that drive the symptoms in long COVID? In some cases, it might, but in most cases, in my experience, it doesn't. And then you've got just the miscellaneous organ damage. You know, COVID can tank your thyroid. It can attack your pancreas and cause type 1 diabetes. It can, damage your ovaries or your kidneys or your liver. And that can be an overlay on top of or independent of the other patterns. So I see 6 basic patterns, or I categorize things into 6 basic patterns to try to simplify and narrow in or focus in on the most specific to the person.
So if we're looking at these patterns, and for each one of these patterns, we see some examples of what might fall under there. One of the things that I don't see is pretty common in acute COVID infections and lingers for a lot of people, and is just like super terrible and frustrating, which is anosmia or hyposmia, like the loss of smell, either completely or partially.
Yeah.
And where would that fit into this picture? And what do we know about that? And do we have any strategies? Like what are your thoughts about addressing that particular presentation?
So that presentation arises from damage to nerves from the virus. And like much of pattern 1, probably the most important thing is time and letting the body go through its normal repair processes. You know, like nerves in the central nervous system have great difficulty in significant repair, but peripheral nerves have a pretty decent ability for repair. It just takes a while. And so the changes in smell or loss of smell, you can try your neuro anti-inflammatories, the things that seem to work as anti-inflammatories most strongly on the nervous system and brain. And I think there's also a big role for scent retraining. It's, like anybody that has had nerve damage, you have nerve damage in your hand, using the hand and exposing it to new sensation is part of the process of repair, or it speeds the process of repair. Demanding that the body respond to input helps to drive positive adaptation. And so I have used scent training or scent therapy since the very beginning with these little personal inhalers. And we come up with different scents that people like, and then they practice smelling them. Mm-hmm. And the more you practice, the better you get at smelling. So I go after that particular presentation with my favorite neuro anti-inflammatories are saffron, boswellia, and lithium. Mm-hmm. And so I typically will use one or a combination of those, and then the scent retraining as a very important part of that. Have you found any particularly effective strategies for that one, Jim?
I think that a combination of time and this idea of like really like finding strong scents like that and are familiar with, and this is the case for a lot of essential oils, just this is peppermint, this is eucalyptus, this is that. I mean, maybe the most extreme case is like, lock someone in a sleeping bag with a skunk, but it's not practical for most people.
Mm-hmm. Yeah. Well, I mean, where is there a place that you can just like order a skunk?
Well, they have bee sting therapy, right? Which is also has been helpful as an anti-inflammatory and everything. And I don't know why we don't have like skunk therapy. Maybe you could go and, like you drive down a bumpy dirt road in a bus with several skunks. And then, like worst case scenario, it doesn't work and you don't know that what you smell like.
It sounds it's
can't go home. No one will get close to you.
Yeah,
there's problems with it. It's not fully worked out.
I think it's got a good basis to it. You're mobile. You're in a bus, so right. You can go around and help a lot of people. You carry all of the people that have lost their sense of smell around together at once with the skunks. It doesn't have to be a one-on-one thing. You do group therapy.
And also the bumpiness is going to be good for your lymphatic system. So when a lot of people think about like, probably I would say for your average herbalist, mushroomist, if they think about things that are sort of like well-known or thought of as being like first go-tos for helping with nerve damage, I think most people would think of St. John's wort. I think a lot of people would think of lion's mane mushroom. Do you have opinions on either of those?
St. John's wort works better than lion's mane mushrooms for long COVID, in my experience. I have used more St. John's wort in the last few years than I have in the last decade. Part of that was getting a really good source, and part of that was long COVID. Of course, you've got the issue where a lot of medications might have potential interactions. And I think that with St. John's wort, a lot of people probably underdose it. So a lot of people make their St. John's wort tincture fresh, which winds up being about a 1 to 15 dry herb equivalent, and so it's about a third as potent as a 1 to 5, and then they're worried about side effects and interactions, so they're only taking 10 drops, 20 drops. In my experience, it takes more than that to see good results. But I like St. John's wort because of its serotonergic property, which drives brain-derived nootropic factor and improves neuroplasticity, like most serotonergics do. And I think it's a pretty potent anti-inflammatory. So it's definitely one of the ones that I use. There was a study that came out literally just a few days ago where they found about 90% of people with long COVID responded positively to SSRIs.
Mhm.
And that it wasn't a complete response, but it was at least some improvement over placebo in about 90% of people, and that's significant. And I think that it's completely reasonable to consider serotonergic alternatives to SSRIs for getting the same type of benefit. St. John's Wort is definitely one of those. Lion's Mane, I see such inconsistent results with Lion's Mane. When it works, it seems to work really well, but figuring out who it's going to work for, or maybe why it's working for some and not others, is difficult. And also, like, all of the research on the compounds in Lion's Mane that stimulate nerve growth, all of that research was done on mycelial extracts, and the fruiting body doesn't contain those compounds.
Mhm.
And I'm more of a fruiting body person than extracting a mycelium. So maybe it's my preparation, and I should just use the mass-produced mycelial stuff and see how that does. But with my fruiting body fluid extract, I have not seen consistently positive results in long COVID. But I have seen consistently positive results with the St. John's Wort, Canna, and Albizia as a serotonergic, with St. John's Wort having that added nerve regeneration aspect to it.
Yeah, and for people that might be like, wait, dried St. John's Wort, let's just take a moment to say that, not dissing any of the suppliers of dried, cut, and sifted herbs, because they do a good job and they're doing a certain thing, but St. John's Wort is poorly represented in its potential by commercial grade cut and sifted dried herb. It's like basil. You can't have really old basil and still have it smell really basily and do all the things you want basil to do, maybe in your cooking or in your teas or and any other preparation you make with it. And St. John's Wort is also more delicate like that, but really good quality dried, freshly dried St. John's Wort is pretty amazing stuff, and it's still quite aromatic and pretty wonderful.
Yeah, it's amazing stuff. And the idea that it has to be fresh, I'm pretty sure came from Michael Moore. Howie said that he asked Michael about that. And Mike was like, no, it doesn't have to be fresh. And Howie said, but you put that in your book. And Michael said, yeah, well, that's because all the dried stuff within 100 miles of me was crap.
Right, yeah. Yeah, I think that's the case. I mean, I say the same thing about like cleavers and a lot of the other herbs. There's a big difference between saying the dried herb doesn't work when it's commercial cut and sifted and you don't know how old it is or where it came from. And this is not all dried herbs, it's just certain dried herbs and something that's been freshly dried and still looks very vibrant. Everything.
If you've got fresh tincture, it works. You just need more than you probably think. I would say that starting dosage of a fresh tincture would be somewhere a teaspoon or more. Versus a freshly dried 1 to 5, I think 1 to 2 milliliters is probably more appropriate. So you can get it, but if you're going to use the fresh tincture specifically for long COVID stuff, more is necessary in my experience.
Yeah, so it seems like most people, although it's terrible, their sense of smell does come back slowly over time. Very unfairly, a lot of people might initially have their sense of smell return from not smelling anything to having everything smell terrible. And most people go that. There's some outliers where it's still like a long-term struggle, and I just don't have a great solution to those cases where it's been a really long time. I wish that I did, but I don't know what it is.
I need to dig into it. A study came out recently on the potential for viral persistence in those cases of long-term loss of smell that like just wasn't responding. But I haven't dug deep enough into the literature to know like what percentage or, and there's obviously like nothing, no studies on antiviral treatments in those cases. I think we'll start to see antiviral treatment studies for long COVID come out pretty soon. We don't have one yet, but it'll be interesting to see how that pans out. You know, the long-term treatment with antibiotics for chronic Lyme disease didn't pan out at all. Multiple
Mhm.
studies have found that that didn't help, and so it'll be interesting to see if we get any studies indicating that viral persistence is maybe more prevalent than we thought.
So oh, you've got pattern numbers in your handouts, but not at the little flower diagram I'm looking at. But if we go into cardiovascular
Yep.
implications and damage and issues, um, there's a few questions, and maybe we'll start with the what is the current understanding of blood clotting or micro blood clotting, and then strategies we might think of to address some of that.
So it seems like that has the different varieties of COVID and the different population levels of immunity have somewhat shifted symptom presentations.
Mhm.
You know, like I started working with long COVID folks just a few months after the pandemic started, well before there were vaccines or any idea what was going on. And those people seem to have a much worse respiratory patterns
Mhm.
than the people that got Lambda or Omicron. Delta was a mixed bag. Um, so clotting risk is increased for everyone after COVID. What's interesting is that actually hasn't been studied for other infections, and now they are starting to do that. So it could be that there is an increased clotting risk after the flu or after other coronaviruses, rhinoviruses. They're starting to explore that now, but if it's there, it's probably not as prevalent as with COVID. COVID seems to infect the arterial plaque and kind of sequester itself in arteries and then drive arterial inflammation that causes plaquey eruptions, leading to clots and heart attacks and strokes and things like that. So one of the things that we haven't talked about is like just what type of baseline testing should everybody get if they have symptoms of long COVID. A D-dimer test, I think, is pretty important. That's one of the clotting tests. And in people that have the elevated D-dimer levels, there's, depending upon how increased it is, there's, you know, a proportional increase in risk of clotting. And so I think some people, especially with a pre-existing history of clotting or a pre-existing history of heart disease, should consider pharmaceutical blood thinners. But for the majority of people, there's a very good chance that the benefits aren't worth the risk.
Mhm.
And also, we don't know how well herbs or supplements work as preventatives. So theoretically, vitamin E and fish oil and nattokinase should decrease the risk of clotting. But herbal medicine is one very long story of theoretically this should work, not working out.
Mhm.
And so what should we do? I think don't get your heart rate over 100 for the first 6 weeks after COVID, and eat lots of fishies, cold water fatty fishies, if you are at a higher risk of clotting naturally, and consider supplementing with vitamin E and or nattokinase, knowing that there's no research showing any benefit, what there is theoretical benefit.
Right. Yeah.
Also, just so everybody knows, like when I was experiencing some heart stuff, Jim was my herbalist. So, Jim, what do you think about some of the cardiovascular issues and clotting issues after COVID?
So one of the questions was, I have two family members with myocarditis, one that now needs a heart transplant. Is there a way to repair or restructure cellular damage created by COVID? And I don't think that, especially if we're talking about herbs and supplements, we can say like, yes, there is a way to repair and that cellular damage. But I learned just a ton from the early work of an integrative cardiologist named Stephen Sinatra.
Hmm.
Um, Towards the end of his life, and he sadly passed away a couple years ago. He had his own supplement line, and there was a little bit of like the health celebrity thing going on, and there was a little bit of I mean, I think being outside in nature barefoot is amazing, but I don't think that the grounding or the earthing thing is maybe like quite exactly the very dramatic physiological things that he was really into. But still, I'm all about it. But earlier on, he had built upon the work of someone whose name I don't remember, that was really into like CoQ10. And coenzyme 210 is like this vitamin-like antioxidant, which is also really good at helping support ATP production in the mitochondria, as well as your body uses up that ATP, taking the breakdown products and making more ATP more effectively. And so he started off there, and then he went on to say, like, well, in addition to the CoQ10, we want to maybe consider L-carnitine. And there's different kinds of L-carnitine. There's L-carnitine tartarate. There's L-carnitine fumarate. There's a few different forms of acetyl L-carnitine, which is the kind that is known to cross the blood-brain barrier and said to be more specific to a lot of cognitive issues. But the one that is most specific to the heart cells is GPLC, or glycine propionyl L-carnitine. And that's the one that I've tended to focus on. Oh, look at that. That's I think they put propionyl L-carnitine with glycine because GPLC is trademarked by a specific company, right? Crazy, but true. And then in addition to those things, magnesium, which is just a needed nutrient for all of the processes leading to ATP production, and something called D-ribose, which is a raw material for ATP. And so this combination of CoQ10, a form of L-carnitine, magnesium, and D-ribose was something that he used very effectively with a lot of results, positive results, for people who had cardiac injury from heart attacks, or who had heart failure. And it was documented to show improvement, show improvement in ejection fraction, show improvement in lowering inflammation, and just like after cardiac damage, your heart can either remodel to the damaged state that it's in, or reverse remodel back to the functional state that it's supposed to be. And this protocol appears to help with reverse remodeling, which is what we want to have happen. I started adding taurine, and there was also a question about taurine somewhere here. I started adding taurine to that, which is also something that is an anti-inflammatory, and something that improves ATP function, and something that is both just on a strict cardiovascular level, like my go-to for arrhythmias and palpitations, you just get straight taurine. The dose is like between 1 gram and 3 grams. Um, I know someone who took more than that, had an unpleasant
Me, I did. I took more. I don't. How did I describe that process to you, Jim?
I think I, I can use what some people might consider inappropriate language. I think what you said was it makes you piss out your ass. I'm pretty sure that's the
Yeah,
message I got from you. See how I was going to anonymize you there?
yeah, yeah. No, no, it's totally a thing. When Jim says, take 1 gram or two, and no more, he means it.
Yeah. But I would use it between the 1 to 3 gram, start with 1 gram, increase dose. And it found that to be really helpful for arrhythmias, tachycardias, palpitations, when that's a major part of the presentation. But I also learned about it from, maybe you're on here. Hi, Emily Springfield. For post-viral fatigue.
Mhm.
And so this was something, and if you, I do not know the name of the article, but you can go on to like PubMed, and there's some articles on taurine that just go through and show like, oh, on this system, it's helpful for this and this and this, and helping with post-viral fatigue is something very specific that it seems to help with, and maybe part of that is through helping improve ATP production. So there was like a separate inquiry on mitochondrial dysfunction.
Mhm.
And if we think about the mitochondria as being the producers of cellular energy, or ATP, I can't say what ATP stands for out loud. Thomas might be able to, but
Adenosine triphosphate.
okay, there we go. So, how about DHA?
Oh, hell no.
Um,
Acid, DH acid.
DHA, that's pretty good. Um, so yeah, taurine is something that I will not always, but often add to that mix. And then I'm going to think about a lot of the, what I would consider like vascular anti-inflammatories, such as vitamin D, fish oil. I mean, ideally, if we can all afford it and know how to cook fairly decent, wild fatty fish is the best way to get, you know, the omega-3 essential fatty acids. It does appear when we look at some of the studies that have been done, some of the conflicting studies that have been done on the activity of fish oil, that there's more consistent results with fish oil that is higher in EPA than DHA. At least the last time I looked, there might be a new study out last month that I haven't seen yet that flips that around again. But if you get something that is like sardine anchovy based, then that is going to be higher in EPA than it is in DHA. And because I know it's a concern for people, if someone out there is vegan or they don't do fish, and they don't want to do krill and they don't want to do green lip mussels or ratfish, is ratfish oil. There is algae-based DHA EPA. I'm pretty sure that one's higher in DHA. There's a company called Vegetalogy. I heard about it from Desiree Sargent. And that one seems to have the most appreciable levels of omega-3s. So if you're vegan and you're like, I ain't doing fish oil, I ain't doing any of these things, that are in the Animalia kingdom oil, you can get algae-based omega-3 supplements, but I would say that 98% of them are horrible and they have clinically insignificant levels unless you were to take like half the bottle in the morning and half the bottle later on. The two companies that I know that make products with decent levels would be Vegetalogy and Nordic Naturals as being reliable. I've met some people that they're like, I'm not going to buy it from them because they still make fish stuff. So
Right.
yeah, that's okay.
Have you tried the algae oil yourself though?
I tasted it.
I got the liquid for I was when was that? Well, I don't know. So I was running in-house retreats here for people with chronic illnesses, and some of the people that I worked with were vegans and wanted to do like the full protocol with vegan algae oil. So I ordered some bottles of liquid because it's like you have to take 10 or 15 pills to get a decent dosage in. And I tried it, and I have a strong stomach. Like, I can take all types of nasty herbal stuff. And I've got to say, it was one of the worst things I've ever put in my mouth. It was fishier than any fish I have ever eaten. And it lingered for hours, and I belched the flavor for hours. It was, well,
But it didn't have a face.
but it did not have a face.
Yeah.
What about oysters? Do they have faces? Because oysters are really high in omega-3s.
Oysters are, yes. There is green nip mussel oil. They have lips.
Oh, lips, no eyes, half a face.
Yeah, something like that.
Okay.
I mean, I want to have options, right? Because like there are people that I know who will be like, well, if you're gonna, if you're not gonna eat this, I guess you're just gonna, stay sick and not get better and have this nutrient deficiency. And I think like, well, we don't need to do that. We know, like, I'm not the one taking the algae oil. So if they don't want to have fish oil, they don't want to have any of the animal-based omega-3s, and they want to do the algae thing and deal with the flavor or taking more capsules, that's good. But getting a product that has higher levels will, if you are taking capsules, will lessen the amount of capsules that you need to take. I've always personally felt like, at least with fish oil, I see more fish burps with capsules than I do with oil.
Yeah.
And I think that's because like everything hits your stomach in a capsule, and then all of a sudden the capsule dissolves. Like, oh, there's a blob of oil there.
Right.
But yeah, that combination of CoQ10, some kind of carnitine, D-ribose, magnesium, maybe taurine if there's tachycardia, arrhythmias, post-viral fatigue, and then sort of our vascular anti-inflammatories. If there's elevated blood pressure, one of the things that I'll think about, in addition to and along with potential herbs I might use for that, is L-citrulline, which is converted by your body into L-arginine. But unlike just a straight L-arginine supplement, isn't ghastly tasting, because that's also horrible. And actually, your body makes more arginine from citrulline than you would get from taking even higher doses of arginine. So that's been a strategy, and that helps to basically have your blood vessels produce more nitric oxide to open up and dilate the blood vessels. Another thing that's helpful for that, and my favorite of all things, I know beets are popular, different kinds of beet powder supplements. You can use those, they're great. Also, beets are delicious if you roast them. But arugula is like really spectacular in terms of its ability to increase nitric oxide levels. Garlic, there's a lot of dietary things we can do. There is something that I'm interested in, but it's so expensive. It's really hard to figure out who can afford it to try it out. And it's this stuff called Arteristil, and it is made from something that is sometimes called an algae and sometimes called a seaweed, that is quite demulcent. And what it has been shown with this product, and there's pretty much like this product that there's been studies on, so sources are limited, is that on that, oh look, it's a blood vessel. Oh look, there's a little black lining. There's like a one cell lining of your endothelium, and that's the part that gets inflamed, and that's where plaques are forming, and that's where, if you have vascular damage, that's where most of it is occurring. On the surface of that one cell endothelium is something called the glycocalyx, and it's a slime layer, right? It's like a slime layer that sort of like coats that tissue. And what they found is that with increased vascular inflammation, you have a deterioration of the glycocalyx. And at least studies presented by Arterosil have said that, this has been shown to improve that and lessen vascular inflammation, increase the presence of the glycocalyx. But it's like $100 a bottle retail. And, that's for like a month's worth.
Mhm.
And that just kind of puts it out of my ability to have a bunch of people try it
Right.
and really see what the results can be. It does make me wonder about, just because I'm a nerd and I like slimy things, this idea, because I think most people would say, how do demulcents affect the cardiovascular system? And probably the best I could come up with is like, oh, well, the soluble fiber um, is going to help decrease the absorption of cholesterol. And that could be helpful so that some of the pro-inflammatory forms of LDL are less absorbed. Um, but now I wonder whether there might be like vascular demulcents, and it makes me wonder about things like cactus or linden.
Mm.
But that's just speculation. I got nothing to go on there than wondering and speculation and like, because
We
I
need to
don't.
get this company the next time they do a study to choose linden as the placebo and see what happens.
Right, right. Linden, cactus, and whatever the name of this particular algae seaweed is.
Yeah,
So,
fascinating.
that one's something I like want to think about. I'm intrigued by it. I want to learn more about it, mostly because of my fascination with slime, and the anti-inflammatory effects of slime. Like, makes sense.
And
But I don't know. I don't have
yeah,
enough going on
well,
there.
I think if we're considering vascular anti-inflammatories, maybe a reasonable intervention for everybody with long COVID is blueberries, right? Like you have these anti-inflammatory pigments in blueberries, and they probably exert at least some of their anti-inflammatory influence by modulating the microbiome. They're,
Mhm.
the pigments are like selective prebiotics, so you get improvement potentially in both GI and cardio with a commonly eaten food. I'm
Yeah.
down with that.
Yeah, I make a an amazing syrup, and so it is a syrup. It is high in sugar, but I take like a gallon of sweet apple cider, not hard cider, and I'll throw in like a pound of dried hawthorn berries and a pound of frozen blueberries.
Mhm.
I'll reduce it down to 2 quarts or half gallon over low heat. I'll strain out the berries and then reduce it down to a quart. And
Mhm.
then you don't have to add any other sugar. Once you do that, it gets to a syrupy level. Um, and it's delicious. And you can take that by the spoonful by itself. You could add other tinctures to it if they maybe don't taste as good and you want to have something to make them more palatable. Or you can stir that into tea. You
Mhm.
could, if you don't think it's terrible, you could put it over ice cream. If you do think that's terrible, you can not have ice cream.
Yeah. I think syrups are excellent in people convalescing because you so frequently have that problem of insufficient calorie intake.
Mm.
And if you can administer potent herbal medicine and also calories at the same time, makes sense too.
Yeah, and dark colored berries are awesome because like all the different extraction methods extract the anthocyanins, right? So you can make it like when I first made it, I thought I was just making it because I make tinctures of a lot of things that I wouldn't normally use a tincture of to pass around in classes
Mhm.
because I can't pass around cups of tea in class, right? I can pass around a tincture though. And I made some bilberry tincture.
Mhm.
And I was like, okay, this is just amazing. But the anthocyanins are extracted by alcohol. The anthocyanins are extracted by water. They're heat stable. There's just a lot of different ways to take it. The freeze well. And one of the reasons blueberries are so awesome is because frozen blueberries are relatively affordable. You can get frozen blueberries relatively affordable. The freezing process increases their bioavailability because if the stuff is inside of the cell wall, which is made out of cellulose, and you freeze it and the water expands, it breaks open the cell wall, which is why frozen berries are so much more mushy, but you get better bioavailability from them. David Winston, of course, makes a really nice salad extract of blueberries and of hawthorn, which is that's pretty wonderful. But if you want something you can make yourself, I totally think the apple hawthorn blueberry syrup is pretty yummy.
Yeah, I think like blueberry hawthorn jam is a legit thing. It's good medicine. And making solids extracts is just dehydrating your syrup down until it's no longer dehydratable, and or that's mostly the process.
So, do you have maybe like a book you could recommend that talks about how to make a salad extract?
If you're asking, is that recipe in my medicine making book? I honestly don't know.
Uh,
It might or might not be in the medicine making book.
okay.
I don't have a good answer for you.
Yeah, I tried to set you up.
It was a perfect setup. I wish that I had a good answer for you.
Okay, we bantered for a while.
We did. Where are we at?
Well, we were doing cardiovascular stuff, and we talked about, well, arrhythmias and clotting and
Mhm.
vascular inflammation. So I think that can cover a lot of that, just because we should move on to some of the other areas.
Okay.
Um, how about that? So, someone asked, how do you handle lung scarring and recurring viral infections?
That's difficult to lung scarring is no matter the cause a difficult condition to work with. I think about kind of a few different potentials. First off, the level of symptoms that you have don't always, or maybe even frequently, correlate with the severity of damage. Maybe this goes back to you can build wellness within an illness. And so even if you have lung damage, there are things that you can do to alleviate the worst of the symptoms. Those things are just good energetic herbalism. If your lungs feel tight, relax them. If they feel dry, moisten them. Changing the sensory experience with your lungs often results in significant symptomatic improvement, even if your lung function itself hasn't improved.
Mm.
We find this in several studies where they have looked at herbs in asthma. And they found that lobelia and kella and a number of herbs effectively relieve the tightness, the pressure, the constricted feeling, but they don't actually change your lung capacity or volume like other medications might. And so I think that good tissue state energetics is really important for quality of life, whether it impacts the actual lung function or not. For fibrosis, the couple of strategies that I might try are, number one, pretty significant doses of N-acetylcysteine to increase the lungs' production of glutathione itself. You can nebulize glutathione, but glutathione is an intracellular antioxidant. It's produced inside our cells to mitigate the damage from other cellular byproducts. So like you mentioned nitric oxide in the arteries. That is wonderful there, but in other places of the body, it can be an oxidant and cause tissue damage. And so glutathione would help to neutralize that inside the cell. but there's no transporter for glutathione through the cell wall. It has to be produced in the cell wall. So
Mhm.
nebulizing glutathione is a very effective mucolytic and does potentially reduce lung inflammation, but it also doesn't do the same thing as increasing your lung cells' glutathione production internally.
Mhm.
So holding space for both. And then the most effective therapy is one that's difficult to access here in the States. It's nebulized unfractionated heparin. So the blood thinner heparin that is a blood thinner intravenously doesn't do anything like that when you nebulize it. Rather, it essentially promotes tissue remodeling and reduces scar tissue. So there are multiple studies dating back to the early 2000s using nebulized unfractionated heparin for lung fibroses from smoke damage, from COPD, but it's not an approved medication here in the state. Well, so the unfractionated heparin is, but it's not approved for nebulizing. So getting somebody to give you a prescription for it is rather difficult. Um, some people source the raw material from pharmaceutical suppliers in China and do it themselves. That's an option, but it's also fairly expensive. I think maybe the smallest quantity cost around $2,000.
Yeah.
Um, so I think that's probably the most effective. And then I'll wrap up the answer to that question with like never underestimate trophorestoratives. And for the lungs, I think of Prince Singh Pseudostellaria heterophylla as a really amazing trophorestorative. I think to a lesser extent, probably Elecampane and Lovage have some of that same trophorestorative action. Do you have any favorite lung trophorestoratives, Jim?
So I'm not surprisingly going to talk about, and for an herb that I have popularized for respiratory issues that to my knowledge had not been widely used. And I'm not saying that no one else ever used it for respiratory issues, but I started using New England aster
Mm.
maybe like a couple decades ago now. And I don't like to jump to using the term tropho restorative because I think if we just think about herbs that are like good for you and throw that word on there, that word becomes less useful, right? Um, but I can say that there's been, and now not just in my experience, but in a number of other people's experiences, situations where someone had asthma, they had one of the forms of COPD, and they took New England aster, and it wasn't just helpful, but when they stopped taking it, they retained the bulk of the benefit that they gained from it. Or when they lessened their dose, sometimes to like, they were taking it every day a few times, and then like every day a couple times, and then, every day like once or every few days, and then, like so many of us do, like you do something for a while and then like you kind of fall off of doing it. Whether that's thinking about your posture or exercising or eating your greens every day. Um, but when they fell off of doing it, they didn't have all the stuff come back up because it did seem to have a restorative action. But I use that more in my experience with that with COVID is more in acute infections and not so much in long COVID. Because I've just, personally seen less long COVID cases,
Yeah,
presenting with respiratory issues.
I don't have any current long COVID cases with fibrosis or any really severe respiratory issues. Pretty
Yeah.
much all of
With
mine right now are more of the pattern one with miscellaneous organ
Mhm.
damage or with the pre-existing condition issue.
Yeah, with regard to the fibrosis or
Mhm.
the scarring and the Aster, I've had a few cases of people using it with emphysema,
Okay.
and the experience was that in a very early stage emphysema, it was quite helpful.
Mhm.
But as the emphysema advanced and there was more non-responsive tissue, and fibrosis would be non-responsive tissue, it didn't do a whole lot, and that's it's a hard thing. This was actually a case that I called Thomas and was asking him about, which was I had someone referred to me that had pretty advanced sarcoidosis with a lot of respiratory fibrosis, and it's it's a difficult thing when you talk to someone and you sort of like assess like, oh, this is really pronounced, this is really advanced. um, the the tissue that my strategies would be, targeting is no longer responsive tissue. And I don't want to say that that doesn't mean that there's not hope, that that doesn't mean that there's not a potential for improvement in quality of life or the experience of that condition. Um, but it realistically does limit what we can expect from our remedies. And just like I think a lot of people probably have a scar on their skin somewhere, and that tissue is not the same as your skin tissue was, and it doesn't respond the same as your skin tissue did. It doesn't perspire or secrete oil the same. It's different kind of tissue, and it's definitely very, very complicating. However, that does not mean that herbs we use or strategies that we use won't work on the other tissue that is still there,
Yeah.
because nobody has 100% um, fibrotic lung tissue, because then
Right.
they wouldn't be alive anymore. So um, there's also this, it might be, I don't know many quotes of myself that I'm like, oh, that's a great quote. But one of my favorite ones that I do know is, just because you can't do everything doesn't mean you can't do anything. And that's really helpful. So if you're in a situation, or you're working with someone who's in a situation, and you're like, oh wow, things look kind of like grim, and like I don't really see that I can make this all better. And I know that that's our goal as much as we possibly can have it, but that still doesn't mean you still can't do things that can improve that person's quality of life.
Mhm.
And improving someone's quality of life is huge.
Yeah.
That's not a little thing, that's a huge thing.
Yeah. I mean, maybe a bigger conversation at some future time. What is the purpose of herbal medicine? What is its end goal? You know, modern medicine, I think the purpose is to cure disease and relieve pain. And there are many instances in which they do excellent at that. But I think that maybe a more traditional goal of herbal medicine, and one that I think has significant benefit and is under recognized, is simply the relief of suffering.
Mhm.
You know, so I people for some reason have this idea that like you shouldn't address symptoms, you should try to get to the root cause. Oh my
Yeah.
God. No, like relieve suffering first and foremost. And you can search for the root cause and work on that while you're also relieving suffering.
Right, yeah. And I mean, a lot of, what we call symptoms, they're immune responses, right?
Yeah.
So like coughing is an immune response, fever is an immune response, inflammation is an immune response. And so you
So
know.
if we just take an herb to kill our immune system, then we've gotten to the root of it, right?
Yeah, I think what people probably mean to say is, like mostly don't try to suppress symptoms. And I say mostly because there's a time and a place for that. Um,
Mhm.
but yeah, I mean, I like symptoms to me are a language that I try to interpret that gives me an idea what's going on,
Yeah.
you know. So
I
like,
I think a lot of it is pushback against shitty medicine, right?
yeah.
Like uh, when we say like we want to search for the root cause, a lot of times what we mean is we want our practitioner to listen to us. We want them to acknowledge our experience. We want them to like believe our experience and try to help. And that's a very different thing than what many people have as interactions with mainstream medicine, which is a shame.
Yeah, and I think it if I thought about like this idea of like getting to the root cause, it's like, well, sometimes it's really hard to figure out what the root cause is, right? And if you can't figure out what it is, how are you going to get to it? If I thought about like how I use Solomon seal for joint inflammation and injuries,
Yeah.
um, the indications I would use is inflammation caused or aggravated by dryness.
Mhm.
And if I think about cause, it's like, well, did the inflammation cause dryness
Mhm.
that resulted in joint pain? Or did dryness cause friction that caused inflammation that resulted in joint pain? And a lot
Mhm.
of times I have no idea where something started,
Mhm.
but I can still see that there's a pattern of inflammation with dryness and be like, okay, I don't know what the starting point is, but I see those two things. You know, this is sort of like my strategy for addressing that particular presentation pattern, you
Mhm.
know. And presentation is, I think, like not the symptom someone has, but the way that they have that symptom, you know.
Yes.
And that is the uniqueness of that individual, often has a lot of constitutional aspects. And what I would use to say like, oh, I need an anti-inflammatory or an expectorant or a diuretic, which kind of expectorant or anti-inflammatory or diuretic do I need, has to
Right.
do with what their presentation is. Um, just a question. This is something I don't have experience with, but there is information about therapeptase, you know, being used to help with scarring and to lessen scarring. Do you have an experience with that?
Not really. Not in long COVID. I have done the lumbrokinase and the nattokinase,
Mhm.
but not the serapeptase.
Yes, so that's good because one of the questions that came in was what about worm enzymes for clotting? So I've used nattokinase as
Can you
nattokinase.
monologue for a few minutes and let me? I've got like the bladder of a 6-year-old and we're 2 hours in, so I'll be right back.
All right, I will monologue. So nattokinase is extracted from a fermented soy product called natto. And I was just at a celebration of organizers of the Great Lakes Herb Fair just on Saturday night. That was like 2 nights ago. Um, and someone had brought some natto, and I saw it there, and I was like, "Oh, natto!" And my first thought was like, "Yeah, I'm not going to have that," because I've had it before. But a bunch of other people had it, and so I got to watch them eat it. And first they pick it up with their spoon, and there's like this stretchy little viscous slime coming up from the natto to where their fork is with the natto on it, which always makes people kind of go like, "What?" But it was herbalist, so we liked emulsions. We're okay with that. And then I was like, "Oh, cool! I get to see their facial expression when they eat it." And they tasted it, and I saw the like, "Oh, that's interesting," and like, "Oh, that's yeah, interesting." And my description of it would be like, okay, first texture. Do you know how like if you have noodles that are left over from cooking something, and you put them in your fridge, and then they get pushed to the back of the fridge and they get forgotten about and they go off and they develop a slimy film over them. That's like the texture. And then the flavor is like stale coffee, like really stale coffee with that kind of like slight, oh, natto. Have you eaten natto?
Oh God, with the slime.
Yeah, okay, so let's see what you think about this description of the flavor and texture. It's like really stale coffee with the slimy texture of noodles that got pushed to the back of your fridge about a month and a half ago. And they got like, they're slimy because they're gone bad. So it's not just the texture of the slime, it's the off flavor of something that's gone bad attached to a stale coffee flavor.
With the after swallow scent of a bad blue cheese.
Oh, okay. Yeah. Yes.
Yeah, it's
This,
disgusting. I'm so glad a supplement exists.
I would like to announce our sponsor, the natto Appreciation Society of North America. So nattokinase, it's extracted from natto so that you can get the benefits of it without having to have the interesting flavor and after flavor and mouthfeel of it. And it is something that lowers fibrinogen levels. And fibrinogen converts to fibrin, and fibrin is kind of like the lattice work that vascular plaques can form on. And so if there is less fibrin, there is less of that lattice work for clots to sort of like form onto. And so it's not a blood thinner like an anticoagulant, and it's not a blood thinner like an antiplatelet, but it still has maybe an anti-clotting action by lowering those fibrin levels. And maybe Thomas can expound on this further. And this is why the casual use of the word blood thinner is problematic, because there's a whole bunch of things that get lumped into blood thinner that work through very different mechanisms that don't really have a commonality to them.
Yeah, I mean, like capsaicin is an antifibrolytic, but it's not a blood thinner, but it does help to prevent excessive clotting. But also, most people with long COVID can't take very much of it because of their GI. So, yeah, it's all complicated.
Okay, so serrapeptase, we'll save that one. That's a good one. That's some good conversation happening. We talked about taurine, talked about blood clots. Can organ damage caused by COVID be reversed?
So, I think, is it possible? That depends upon the organ. So our organs all have an ability to self-repair, and also them self-repairing to a clinically significant level is different than them self-repairing. So I think it just depends on the organ. There's no magic remedies. Like I do think that organ-specific tropho-restoratives are a thing and can and probably should be tried. But also, a lot of times, once the damage has been done, even if your body can repair it, it won't return to full functioning. So, you get COVID and it tanks your thyroid. Your thyroid has, the cells themselves have been damaged. Can your thyroid heal? Yeah, I've had clients who had their thyroid removed and they missed a little piece and it regrew. Will it, though, is the question. And how often does that happen? And the answer is, I don't know. And it seems to be super variable. Um, like I depends.
Yeah, so like if it maybe to use a different condition, but like if we think about like someone has chronic renal insufficiency or kidney failure,
Mhm,
and then they're like, oh, well, nettle seed can be a trovo restorative
mhm,
situation, and that is true, but that doesn't mean that it takes kidney level functioning from like 18% back up to like 98%, right? So
right.
you can have improvement, but that doesn't mean that it is total improvement. Like, improvement does not mean improvement all the way. And maybe this sort of like, and this is a larger concept or topic in herbalism, but a lot of people, if they've been sick with something that is more than a passing, trifling, transient thing, or they've had an injury, a lot of times a person's therapeutic goal is for themselves is, I just want to be like I was before.
Mhm.
And I totally understand that. But
Have you ever had any significant challenges that you wish you could be like before, Jim?
yeah, it might just not be a realistic goal, right? It might not be something that if that's what your goal is and that's what you're focusing your energy on, and not being like you were before
Mhm,
is going to dash your hope and make you feel defeated, all of which generally makes people feel not very good.
mhm,
Um, that can undermine your improvement because you're like, I'm still not like I was before, which means that I'm still bad. I'm still not okay. I'm still haven't got there, rather than saying like, okay, life threw me a curveball. And it keeps throwing me a curveball for the last, however many months or years. Um, but I'm going to try as even though that goal is completely understandable, I'm going to try and like gauge how I'm doing on like how am I doing relative to how I was doing? Am I seeing improvements?
mhm,
When I am implementing strategies and making changes um, that I feel confident or I have an understanding will improve my health, am I seeing those improvements?
mhm.
Even if I'm seeing setbacks, even if I'm seeing flare-ups, like, am I seeing those improvements? And also, and I totally get the challenge of this, like, in spite of the difficulties of my experience of this particular health condition, am I still able to enjoy and appreciate my life? Right. So, like, that's, I think, a better strategy and goal to strive for than to be like, I want to be like I was before.
Mhm.
Um, because if that's the goal, and maybe that's like not going to happen in a significant number of cases, then it's like, okay, my goal is unattainable and I'm always going to feel miserable about it.
Yeah.
If the goal is like, even if a lot of today was pretty tough, was I able to find some moments of peace or some moments of joy or some moments of gratitude in the day for what I do have or what I have done, or that I'm still trying, you know? I think you said, I forget how you phrased it, like um, healing, in the face of illness. Do you
Mhm.
remember your thing?
Finding wellness
Yeah.
in the illness. Yeah.
Yeah, so I think even when people talk about health, one of the things that we can often like in holistic worlds and in herbalism, people say like, oh, health isn't, merely the absence of disease. It's about feeling vital and able
Mhm,
and all this stuff. Um, but I kind of think about health as like a very in the moment thing.
mhm,
Like in that moment that you're in, like, are you treating yourself with compassion? are you giving yourself like understanding and, can you be where you're at um, in as good a way as you can muster? And that
Yeah.
might not be like what your goal is, but like you're working on it, you're trying. And that's health. That's the healthy response to the situation you're in. Because I think that if we have a concept of health that says like if I am not vital and able and everything is working, at its prime way, then I'm not healthy. And
Right.
I don't want people to identify with that in the same way that I personally don't like people identifying with like saying like, oh, I'm toxic or, I'm not good or I'm terrible. I don't want people to say like, I'm not healthy. I might be like, wow, today was pretty rough,
Mm.
but I got through it, but I still did this. Or maybe like today was really rough and I'm not really happy with how I handle things. Like I lost my temper and I was maybe like short with my partner or short with kids, or like, my dog all the Hazel wanted to do was play, and I was just like impatient with my dog and I don't feel good about that. I'm gonna let that go and I'm gonna try again tomorrow. That's a healthy response,
Right.
you know.
Yeah. One of the things that shifted how I think about herbalism was when I decoupled like vitality from disease.
Hmm.
And I looking back, I don't know why it took me so long to do that. I know or knew I knew a guy in his like mid 20s, Iron Man, decathlons, martial artist, amazingly healthy, did everything right, was the picture of vitality, and dropped dead of a heart attack after, like, the day after completing an Ironman 100 miler.
Hmm.
Full of vitality, died. And then I remember a client of mine. He was a physician and had terminal glioblastoma. He had a big old brain tumor, and I worked with him for 16 months. He held the record for surviving the longest with glioblastoma without surgery, without debulking in his
Hmm.
state for years. And I remember when I started working with him, he was uh, like over 300 pounds. He didn't really get much exercise. He was very unhappy with life. He had all of these things going on, and then got hit with a cancer diagnosis on top of it. And he passed away about 16 months after his diagnosis. And during that time, he went he dropped his weight down to like 190 pounds, developed muscles in places that he didn't know he had, alleviated his depression, improved his marriage, like became more active in church. He just like he built incredible vitality despite having a terminal illness that eventually killed him. Also, most people with that have a really poor quality of life the entire process. And this guy had an amazing quality of life until he felt bad, and then he laid down and fell asleep and passed away 3 days later with no prolonged suffering, no prolonged pain. Like, I think we can all probably imagine instances in which people with severe disease had lots of vitality, lots of energy and optimism and good health practices. And we can probably also imagine people that had high vitality and all of those things and had issues. It's decoupling those two was a big improvement, I think, for my understanding of health and disease and herbalism and all of it.
Yeah. All right. So how about we go into I think I asked you this on a chat.
Oh yeah.
Do you ever see like anxiety, depression in long COVID? Or how about this? Maybe brain fog,
Hmm.
difficulty concentrating.
Yeah.
And like how do we want to frame the way that we think about that? Maybe like underlying what's going on. And then what would be some of the strategies that you're thinking about implementing to address those
Yeah.
situations?
So um there is a
If
very
anyone's wondering, by the way, I know that that's something that is common.
yeah. Yeah, there's a very high incidence of anxiety and depression in people with long COVID. And one of the few predisposing factors towards long COVID is anxiety, which does nothing for the people that currently have anxiety and are watching this podcast or watching this YouTube. Sorry about that. But like diabetes, obesity, anxiety, those are probably the three biggest predictors of long-term symptoms from long COVID. Uh, so I think a lot of people go into it with some base level of anxiety that gets worse as it probably is reasonable with an acute onset of a chronic illness that you don't know much about or what to do about. The depression piece is the piece that I think a lot of people miss, probably because people assume that you have to be sad to be depressed, which is not at all what depression is. Depression is defined not by sadness, but by a slowing of your thoughts, feelings, and movements. And so you can absolutely have overt clinical depression without feeling sad at all. If you lose interest in normal activities and your feelings are processing slower and your thoughts are processing slower and your movements are slower, that's indicative of depression. Another big indicator is the pattern of insomnia. So with anxiety, the insomnia is often a difficult time going to sleep, but waking up earlier than you want is a classic sign of depression. So teasing those things apart is sometimes difficult. I like to tease things apart. I'm going to share my screen again, and once I find the right thing, because I do have this graphic that shows what my, did I not put it on here? Oh, I did. Here we go. Share screen. So when I was first starting with this course, I actually started on the whiteboard, and then I had a hard time reading what I had written, and so I figured out how to do it on the computer. No, that one.
That,
And
by the
so
way, is earlier when I said Thomas's brain. That's what it looks like.
that's what it looks like. Yeah, pretty much. So anxiety and depression exist somewhere between 35 and 50%. And this is like overt clinically diagnosed. You can obviously have milder forms that aren't represented in this statistic. And here's the thing, like having chronic distress because you're always short of breath or because you can't remember the last time you smelled anything good or because you're always tired or because you always have IBS. These things can lead back to and drive anxiety and depression. And sleep disturbances worsen those things, and sleep disturbances worsen dysautonomia, and dysautonomia worsens sleep disturbance, and anxiety and depression worsen dysautonomia, and dysautonomia worsen anxiety and depression. And sleep disturbance, anxiety and depression, and dysautonomia are all characterized by fatigue and brain fog. So you kind of have to work on all of them at once to start seeing improvement. So you've got to manage the dysautonomia to reduce the distress that you get every time you stand up. You've got to work on the sleep disturbances. You've got to work on the anxiety and mood. And all of that kind of has to happen simultaneously with gastrointestinal building because of the intimate relationship that the nervous system and GI system have. I hope that people can see my little cursor here as I move it around. If not, you're just going to be completely lost. Sorry about that. So what do we do to address brain fog? Well, we can try to tease apart how much of it is just from poor sleep. We can work on improving the quality of sleep and see how much that improves brain fog. Or we can work on it from managing dysautonomia to see how much. Or we can consider anxiolytics and mood elevators. You know, if you take lavender, pulsatilla albizia, and your brain fog goes away, you've probably just clued into one of the primary root causes of that brain fog, anxiety and depression. Or if you work on building your microbiome, if you take probiotics or you do prebiotics, basic GI building stuff, and your brain fog gets better, then you might have some insights as to the specific pattern that led to that. So long COVID is, in my experience, about teasing apart the multiple potential influences on the most distressing symptoms that people have first. The more you understand the potential pathophysiology, I can simplify that like even more. The more you understand how to identify dysautonomia and manage it, the more you can rule out one of the most confusing, confounding factors in the fatigue and brain fog and focus in on other factors. So, you know, the first thing that I would suggest in people that have brain fog is try to work on your potential, especially if they have orthostatic intolerance, work on the dysautonomia. So extra hydration, extra salt, compression stockings. Raising the head of your bed 6 inches is incredibly helpful for dysautonomia, for GERD, for sleep apnea, for quite a few underlying issues. And so, yeah, putting blocks of wood under the head of your bed can significantly improve fatigue and brain fog for some people. So I think focusing on managing this while also working on sleep disturbances, anxiety, depression, and considerations for the GI system is a reasonable starting strategy for addressing brain fog.
So you mentioned pro and prebiotics.
Yeah.
There's a gazillion different probiotics that you can buy, ranging in quality from like it doesn't have any to really pretty good. And I think the last time that I was sitting in on one of your round tables, you were talking about how I believe it was VSL is not the original formula, and now it's maybe Visbiome.
This biome is the original. Yep.
And would that be like in terms of like a badass reliable prebiotic? Would that pretty much cover the bases, or is that like too much for some people? Like, so because a lot of people will hear like probiotics are good, and they will just go out and they'll buy a probiotic, and it might be great, it might not be great.
Yeah.
Obviously, for a lot of the really good ones, like Claire Labs have, are more expensive, not as easy to get. A lot of the more available ones are less effective. Like, how would you think about um, educating people around those particular issues?
Yeah, so I think first and probably most importantly, probiotics, with very few exceptions, don't seem to inoculate the gut. And so the benefits that you get from probiotics are transient and exist only as long as you're taking them. But those benefits are immune modulation, which is one of the goals in long COVID. And so I think that any decent probiotic has the potential to modulate the gut's immune system. And there is probably a dose-dependent relationship. So it's very likely that a lot of the benefits from this biome come from there just simply being way more critters in it than in other probiotics. I tend to focus more on prebiotics than probiotics because prebiotics restore the density and diversity of your microflora better than probiotics do. Specifically, your alpha diversity with prebiotics goes up about 10 times more than with taking a probiotic. So I do consider probiotics in long COVID, and I am honestly very partial to a widely available probiotic called Culturelle. It's Lactobacillus rhamnosus GG. It's one of the most well-studied lactobacillus strains. And I think that's a pretty good starting place for most people. And if you're going to experience improvements with probiotics, you probably will with that product that you can pick up at any CVS or Walgreens. If you do, I think that can indicate that trying other more potent probiotics will also offer benefit. But if you don't, then a lot of times the other probiotics won't offer benefits. So I like the Lactobacillus rhamnosus GG, the Culturelle. I like the Bifidobacterium only probiotics. Their factor 4 with Clear Labs is the one that I use. And I really try to reserve this biome for when there's intense GI symptoms that don't respond as well to other interventions as I like, simply because it's the most costly of those.
So someone in their inquiry about brain fog does, I mean, really pretty nice because they did not know your little flower shaped model here, but they
Oh, yeah.
say, can you address the lingering brain fog, digestive, and histamine issues? So specifically, like with histamine, usually what we're thinking is people are they have histamine sensitivity, or they have mast cell activation syndrome, which is like maybe a more complicated, advanced, reactive form of histamine sensitivity. And
Yeah.
how do you see that? Is that just something corollary to long COVID, or something that long COVID maybe predisposes to?
Yeah. So there are three primary histamine excess patterns. There's histamine excess from overt allergic reactions, which are driven by immunoglobulin E and characterized by B cell release, and this seems to be one of the long COVID patterns is a new onset of classical allergies. And then there's the histamine excess pattern where it's a mast cell activation disorder, and your mast cells have become destabilized and fragile, so they spill their contents under much less stimulation than they did beforehand. With classic allergy patterns, it's normally going to be environmental. So changing the environment reduces the symptoms. Maybe it's seasonal, and the season reduces the symptoms. With mast cell activation disorder, there's normally not environmental improvements or seasonal improvements, and the histamine symptoms are drastically increased. There's often anaphylaxis or a history of anaphylaxis in people with MCAD. And the histamine symptoms affect multiple body systems. So it's a respiratory, urinary, and skin, or skin, digestive, urinary. Most of the time there's a respiratory component. Sometimes there's not, and there's just the skin and other, but it's multiple systems responding to a histamine excess at once. And then there's the third pattern, which is a dietary histamine. It's driven by dietary histamines, and it's a histamine excess, so it creates the same basic symptoms as MCAD or allergies, but it's dependent upon the level of histamine in foods. So the reaction is much worse with fermented foods, with canned fish, with things that have known high histamine levels in them. And the therapeutic approach is different for all of those. With allergies, you're wanting to symptom manage with antihistamines and mast cell stabilizers, but the ultimate goal is to prod the immune system away from Th2 dominant back towards a more normal Th1 dominant system. With mast cell activation disorder, you want to make sure that there is nothing that's no underlying infection that's continuing to trigger the mast cells, and you want to focus most on stabilizing the mast cells. And then with dietary histamine intolerance, which also can happen with COVID, that's probably driven by damage to the cells in the small intestines that release diamine oxidase, which is the enzyme that should break down dietary histamines. And so you can supplement with diamine oxidase, DAO enzyme. If you buy just the DAO enzyme, it's super expensive. You can buy freeze-dried beef kidney pills, which is really high in DAO. And you can also sprout peas, and fresh pea sprouts are really high in DAO. But that one's easy to figure out because it's responsive to an increase in DAO enzymes, and it's responsive to a decrease in dietary histamines. Allergies are responsive to antihistamines, and mast cell activation disorder is poorly responsive to everything, and it takes a lot more work. So in running the differential, I want to think about the lowest hanging fruit is let's rule out dietary histamine intolerance. Go have a can of fish and some sauerkraut, and if you hate me afterwards for how bad your symptoms got, we have figured out our next course of action.
Well, that's interesting, because usually what I tell people is like, rather than take something that's going to cause a flare, I'm like, oh, you're getting flares. How about no? Because removing is tough with histamine foods, because freaking everything.
Yeah.
Right? I mean, like a lot of different things, including a lot of probiotics, aggravate histamine sensitivity. Usually what I'll tell people is like, get a kidney or a DAO supplement. And I think that the DAO that I've used is by Seeking Health.
Yeah.
I'm like, take that about 15 or 20 minutes before you eat. And if you can eat stuff that used to make you feel terrible and you notice it's significantly better, then it's showing you that it's clearly a histamine thing. And it's like a low histamine diet is pretty tough because there's not only the histamine containing foods, there's the histamine forming foods and a
Right.
lot of good stuff, you know.
Well, it's also unnecessary long term. Like I think the role of a low histamine diet is as an assessment, not an intervention.
Mhm.
So you go on a low histamine diet if your histamine symptoms really improve. That doesn't mean you need to stay on the low histamine diet. That means you need to fix the gut problems leading to the histamine intolerance.
Re-
So
Revolutionary. I mean, that's what is his name? Dr. Gio Espinosa is a naturopath,
okay,
and I mean, I honestly don't know a lot about him. I do know, and this is a paraphrase and not a direct quote, but I love it. And it's the diet that got you well isn't necessarily the diet that keeps you well.
yeah,
And I think that that's such a great thing because a lot of people will go on a therapeutic diet and be like, "Oh, wow, this therapeutic diet like really made such a difference. I'm going to eat that way forever." And they identify with that diet and there's a lot of dogma surrounding that diet and how perfect it is. And then after, depending on the diet, a period of time persisting on that diet, they end up with issues related to that diet.
yeah.
So a lot of these interventions, these dietary interventions, may not be long-term solutions. They
Mhm.
might be like shorter term strategies or assessment techniques.
Right. Yeah, I think a lot of dietary interventions are much more appropriate as dietary assessments than kind of long-term plans. But the dietary histamine thing, like you figure out that it's that, and then you start building digestive vitality. I have found that Blue Flag is one of my more important remedies in restoring DAO production in folks. I'm not sure exactly how that works, but it's magic. So yeah, there's that, and then you've got the is it allergies thing? Well, like there's ways to figure that out that are fast and slow. There's traditional allergy testing. Also, if you take Claritin or Zyrtec for a few days and everything gets better, we've got a pretty good idea that it's classical allergies. And then we can transition to, like Boswellia as a leukotriene inhibitor and Echinacea astragalus as Th1 stimulants. And we can work on the underlying immune dysfunction driving the classical allergic reaction. And then if it's MCAD, we've got a lot more work cut out for us. That's one of the more complicated things that can happen.
So someone asked in relation to just fatigue and exhaustion.
Mhm.
What's your opinion on using brain retraining and proper pacing programs for long COVID? Are they helpful, especially for nervous system dysregulation and post-exertional malaise? And then another person asked about post-exertional malaise. What is your treatment approach to PEM, including herb supplements, lifestyle advice?
Yeah.
Um, have you had success in helping people fully recover from PEM? Finally, do you use any lab? Got to find the right paper that it goes from one page to the other. Use any lab tests for evaluating PEM to help direct treatment?
I don't use lab test for PEM. There are none that I know of specific to that. I do think after 20 years of working with people who, and I'm talking before COVID, who came to me with a self-diagnosis of chronic fatigue syndrome, I do think it is vitally important to differentiate being chronically fatigued from having post-exertional fatigue or chronic fatigue syndrome. You can be chronically fatigued, and that can lead to deconditioning, which can lead to post-exertional malaise and fatigue, but the onset is rapid with the exertion. this is very different than the post-exertional malaise post-exertional malaise in and exhaustion in chronic fatigue syndrome and some patterns of long COVID. In those people, the best evidence that we have says that the level of post-exertional malaise is proportional to the amount of antibodies they produce to nervous system tissues. And so the teasing apart deconditioning from it's complicated and difficult. I don't want to underemphasize that. But when there is clear post-exertional fatigue that fits in with a chronic fatigue syndrome pattern and is 100% not related to deconditioning, you treat it like autoimmunity because it probably is. So okay. That's when you go in, and I've taught a very long class on fatigue differentials for years. And one of the things that I have said is you've got to differentiate being chronically fatigued from having chronic fatigue syndrome, because being chronically fatigued could be bad sleep or anemia or hypothyroidism or depression or any number of things. Yeah. But having the specific pattern of chronic fatigue syndrome means that there is probably an autoimmune process in the nervous system going on. Caveat here, like, we're all autoimmune. Like, everybody has currently and regularly produces antibodies to self. There's complicated mechanisms of central and peripheral tolerance that allow us to become reactive to self, but not symptomatic because it's being neutralized by these tolerance factors. And so, yeah, chronic fatigue syndrome in its classic form is probably driven by dysautonomia and autoimmune processes.
So that's a pretty good transition to a few different people asked, basically, has long COVID essentially turning into an autoimmune condition? And to what degree? So like all the time, to some degree, sometimes, but not all the time? Like, how do we want to suss that out?
So I think that the longer it goes on, the more likely autoimmune conditions are to develop, even if we don't have good accessible testing for those autoimmune conditions. Like getting tested for the weird antibodies prevalent in chronic fatigue syndrome and in some cases of long COVID is difficult to do. Like they're tests used for research purposes, not available to average practitioners. And I think that part of the difficulty with long COVID is not just in identifying the triggering factors and initial pathophysiology, but it's also in identifying the sustaining factors. So I think about inflammation as having a trigger and a resolution response, and then sometimes it's re-triggered or continually triggered, and other times the initial trigger goes away, but there are other sustaining factors for that response. So I don't view everybody with long COVID as inherently autoimmune, but many people with long COVID benefit from immune balancing and I think of it as an accelerated autoimmune approach. Mm-hmm. Like there's some autoimmune conditions that if you poke too hard, the person's kidneys or heart will fail, right? Like you don't want to poke too hard at somebody with lupus, maybe even rheumatoid arthritis. But those are more humoral autoimmune responses. And then we've got the cellular autoimmune responses like Hashimoto's. If you poke too hard, you probably aren't going to get a ton of pushback from the body.
Mhm.
I think that in many people with long COVID, you don't. So I've got this autoimmune protocol that is a 6 month step by step, phase by phase protocol. And I think a lot of people with long COVID, you can accelerate that to see results faster because there's not as much of a concern about worsening the humoral autoimmune attack.
All right, let's try a couple of quick things. Are you seeing more or less new cases of long COVID?
More. I'm seeing more cases of long COVID and more cases of pattern one than I was earlier in the pandemic.
And pattern one is neuropsych gastrodysfunction.
Yeah.
Okay. And how about any studies on acupuncture for loss of smell?
No, I mean, not that I know of, but the studies on acupuncture, since they figured out how to do a controlled trial with fake acupuncture, have across the board been like extremely underwhelming and disappointing. So I wouldn't expect there to be much funding for a study on that particular thing.
So this question is about, I think it's about two things. So it's about one thing, but it's really about something else. So the question is, if possible, could you speak to the fear of overexerting due to potential fatigue? I've had COVID for 11 months and perhaps spend too much time in bed when I'm tired and don't want to make myself worse. So there's like the fatigue part of that. But I think a more compelling part of that is like when people are sick for a long time, that like fear of what if I do something wrong and make something worse?
Is the key indication for your previous question, which asked about the brain retraining programs or the limbic retraining programs. So the longer any chronic illness goes on, the more likely we are to have brain nervous system adaptations to that illness. Like we talk about neuroplasticity, which is just a way to describe the learning process in the brain. And it's great. We can, like the dominant characterization of our species is neuroplasticity. We can learn and adapt cognitively at really amazing levels. And also, how we learn is largely dependent upon repeated experience. And so if you are repeatedly experiencing pain, for instance, your nervous system gets really good at feeling pain. They've defined that process as a central sensitization, where your nervous system essentially has deeply ingrained pathways that take nociceptive signals straight to the part of the brain that says, owie, that hurts, rather than all the other parts of the brain to interpret those and give it context. And so the volume is turned up in, like phantom limb syndrome. There's no limb there to hurt, but it's the most painful thing anybody can experience. And that pain is entirely in the central nervous system because of that amplification, because of neuroplasticity. So in chronic illness, your brain can, but doesn't always, become wired to feel the negative symptoms more acutely. The volume can be turned up on your fatigue, on your brain fog, on your whatever the original cause of that can go away, and you can still feel it because the wiring has been changed. And so for people with chronic illnesses that can't imagine recovery, that are worried or anxious about their current state of fatigue, these are the people that benefit the most from actively working on remodeling those brain pathways. And this has been known in clinical research for 30 years. Like, cognitive behavioral therapy is one way, maybe an inelegant way, to initiate brain rewiring. And it's been a mainstay of treatment for chronic fatigue syndrome for almost 30 years. And it helps a lot of people. A more elegant way seems to be, and I emphasize seems to be because there's no research comparing limbic retraining programs with cognitive behavioral therapy for chronic fatigue syndrome. There should be, but there's not yet. But there seems to be a more elegant and faster solution to initiating brain remodeling than cognitive behavioral therapy, and these are called limbic retraining programs. DNRS was the original, or at least as far as I know, was the original. The videos from that look like they came off of a 1990s VSH tape. They're low quality, and because of that, I don't recommend it anymore. Just production quality is really low. But that DNRS was the original, and then Gupta, the Gupta program was the next one that I became aware of. And it was much better presentation, much better production value, same basic concepts. And then most recently, I have delved into the Reorgin, RE-ORGIN. Reorgin is the limbic retraining program that I've seen most recently. And these are typically programs that there's maybe 6 or 8 hours of content, and they're designed to be done like an hour a day every day for 6 days, and then you just repeat them over and over again. But accessing them comes with community forums and coaching potentials and things like that to help you understand what you're doing and to kind of keep you on task. And maybe it's just the keeping you on task and doing them every day in a structured way that makes it seem like they're more effective than a traditional go to a therapist once or twice a month and do CBT about your problems. But yeah, I think for people with any chronic illness that have lost the ability to imagine living a different way, regardless of what label their illness has, doing some sort of neuroplasticity-based brain retraining program is probably a good idea.
So someone asked, any credence to ACE2 receptor inhibition using Biden's Pilosa or Alba, as noted by Buhner? It is abundant around me, generally recognized as safe as far as I know. So I've tried to take it consistently since 2020. Any thoughts on that?
No evidence for it. Like pretty much everything that Buhner said, it was all theoretical, and without evidence, I don't think it's worth the hassle.
Got another one. Where did it go? Scroll. I'm using the thing with my finger to scroll on my touchscreen.
So,
how many
coming in on 3 hours, Jim? I think I'm gonna have to give you like a 10-minute warning. I'm running out of brain juice.
Cool. I'm gonna give you a quick question, and then we're gonna delve into the world of controversy.
Okay.
Because I feel like if I leave controversy out, people will be like, "Oh, left it out,
Sure.
didn't address it, right? So
Yeah.
let's do that. But how many cases have you investigated? Um, to give an idea, like this is like 3 people now.
Yeah, I'm somewhere a little over the 100 mark between my
Uh,
private practice, mentoring graduates, and free clinic work.
okay, controversy. So obviously we can't talk about this topic without vaccination coming up.
Mhm.
And is long COVID related to COVID infection? Is it an adverse vaccine reaction? And I mean, it's well established that there are adverse vaccine reactions.
Yeah.
We know that that happens. Um, it
You might
seems
know more about that than most people.
I do know more. When I was 3 years old, I had Guillain-Barré syndrome after the 76 flu vaccine. I was paralyzed from the waist down for a while. I can walk now. And people sometimes are like, "Oh, what was it like?" I'm like, "I don't know. I was 3. I don't remember." Like I remember being in a hospital and getting a toy shaped like an egg that you couldn't knock over because it's weighted on the bottom.
Mm.
That's as much as I remember. I also remember like I was so like matter of fact about it. I like woke up and I was like, oh wow, like my legs don't seem to work. Like, and I sort of crawled out with my hands and you know how when you're a kid you scooch on your butt down the
Yeah.
stairs. I mean, I haven't really done that in a while. I suppose I still could, but the stairs to my basement are just wood, so I think it would hurt more.
Mm.
Um, Maybe I'll try it.
Mhm.
And then my mom's like, "What are you doing? You got to go to school." I'm like, "My legs don't work." She's like, "Oh, come on, you got to go to school." I ended up, yeah, I had Guillain-Barré,
Yeah.
and I recovered. I don't remember much about it, but so we know that that's real.
Yes.
But clearly, vaccines are a tenacious issue, and clearly there are um lots of different perspectives on them. My perspective, having had an adverse reaction to a vaccine, that resolved but was pretty severe when it happened, like I still feel like saying vaccines as if their one thing doesn't work.
Mhm.
Like it's kind of like saying cancer as if it's one thing and talking about it as if it's one thing rather than like a very nuanced thing. Like there's a difference between a vaccine for chickenpox and a vaccine for rabies, right?
Mhm.
They're
Yeah.
different things. But with COVID, I mean, even though it's not brand new, it is a relatively, some of the Pfizer and Moderna are relatively new technology. People are concerned about it. There's a lot of people can find whatever information they want to find
Yeah.
about it. And so understanding that there is a potential for vaccine injury and
Mhm.
that some vaccine injuries mimic the causes of the illness that they're given from. Like, how do we suss out whether these long COVID cases are from COVID infections or from vaccine side effects?
Yeah. I think that's a really good question. So I started my journey as an herbalist, as an anti-vaxxer. My primary teachers ranged from staunchly anti-vaxxer to vaccine hesitant. I transitioned from anti-vaxxer to vaccine hesitant as I started seeing people and had more experience and learned more. And now I've transitioned all the way to I am generally pro-vaccination. And that transition was not because I was unaware of the controversy or the studies and statistics and people like Sherry Tenpenny and all of the people that have been against vaccines for quite some time. I started there believing that and have slowly changed my beliefs based on new evidence that new to me evidence as I became better at science and interpreting research. So, how do we know that long COVID isn't caused by the vaccines? Number one, I started working with long COVID a year before the vaccines existed. So I know that it wasn't the cause in those cases. Number two, I have current long COVID clients that have never received a vaccine and never will. I don't discriminate. If you don't want to take a vaccine, that's fine. I consider it a reasonable precaution when faced with alternatives like long COVID and acute COVID and a lot of other things. But everybody's entitled to doing their own thing with their own body. So I've got quite a number of unvaccinated folks with long COVID. There is one case report of long COVID caused from vaccination. It is a classic pattern 1 long COVID that occurred like 2 days post-vaccination in one person. There are 16 observational studies encompassing hundreds of thousands of people showing that across the board, long-term outcomes are better in people that got the COVID vaccine, and rates of long COVID are less in folks that got the vaccine. It's not one study. It's not just studies funded by big pharma. We're talking about studies from around the world, many of them funded by governments that excluded big pharma from the conversation, and they all uniformly show benefits to vaccines more so than risk, including reduced rates of long COVID. So could it all be wrong? Could it all be faked? Theoretically, anything's possible. But, I had a student whose mom was a vaccine researcher when COVID started, and we had conversations, and turns out that, like, if you seek them out, you can actually talk to people in vaccine research, and they're not evil, horrible people, and they know as much about safe vaccine development as I know about herbs. That's their passion just as much as herbs are my passion. And I think that to believe that long COVID is nothing but one big vaccination reaction, you have to assume that there are tens of thousands of horribly evil people out there trying to harm you. And when you actually start talking with them, I don't think that holds up. So for a lot of reasons, objective data, including hundreds of thousands of people in very large observational studies, my own clinical experience starting to work with long COVID before the vaccines existed and working with long COVID now in people that have never had vaccines, along with my belief that the world is not filled with evil people trying to kill you and manipulate you, all make me think that the overwhelming majority of long COVID cases are due to COVID and not vaccinations.
Mm-hmm. Yeah, I think I wish like a show like Radiolab or This American Life or Invisibilia, some of these places, really these people that do really good studies that are really thoughtful and really insightful would look at the vaccine issue and say like, like what's going on here, and like rather than just saying that the anti-vaccine, inclined, or the vaccine hesitant inclined, or just ignorant people who don't know anything. Because if we look at a company like Pfizer, right, we can say like, oh, Pfizer made Vioxx, and Pfizer knew Vioxx was killing people for years, and they hid the research and they lied about it. I mean, I remember hearing this long NPR story where they had gotten all the internal documents about how they were actively trying to disparage people who were recognizing the problems with Vioxx rather than admitting that the problems were real, which they knew were real. And with that being the case, it's kind of like the idea that there are a bunch of people who don't trust the drug companies, right?
Totally.
That makes sense.
Yeah.
That's
Yeah.
a reasonable thing. Um, when I mentioned earlier about vaccines not all being the same, I know that a couple of years ago, I think maybe 2 years, 2.5 years, someone who got diagnosed with rabies died of rabies because they're like, I'm not getting a vaccine. And it makes me shudder because rabies is a horrible
Horrible
way,
way to go.
just
Yeah.
a terrible way to go. And yeah, I agree. As someone who's experienced a significant adverse reaction, and I know there are people who got Guillain-Barré who never fully recovered from it. Um, I totally have a lot of understanding for that, but I think that like if we're talking about um, vaccines, it's just to say that they're all inherently bad and talk about vaccines as like one monolithic thing ends up being problematic, you
Yeah.
know. But again, yeah, I didn't want to like not address that because it's a legitimate thing and it's a concern that a lot of people have, you know.
Yeah. And, I it's something that I was on the lookout for.
Mhm.
Um, I I do think that the recent vaccine technology that they've developed has resulted in vaccines with some of the lowest rates of side effects ever. If you just look at like the vaccine that you got in 76, it probably had over 100 times more miscellaneous proteins in it than the current vaccines do.
Right.
Over 100 potential targets for your immune system to react to than the current vaccines do.
And live viruses in a way that is less common now, right?
Yeah.
Yeah, and for me, people were like, actually, I I was talking with someone that I ran into unexpectedly, and they hadn't seen me. If spoiler, if anyone doesn't know this, but back in 2018, I was rather dramatically and very suddenly and seemingly unexpectedly dying. And relevant to this conversation, Thomas came out and came to Scotland and spent a whole lot of time there until it was clear that I likely wasn't going to be dying anymore. Um, and so I hadn't seen this person since that instance happened. It was the first time I'd seen him. And so he saw me and he was really excited. I was just trying to, of course, run into the grocery store and run out. It's just what happens sometimes. You're just trying to do something really quick and you run into someone. And it's not that you're not happy to see them, but you're just like, oh, I just want to be able to like grab my radicchio and get back in the car.
Mhm.
But they had commented like, "Oh, you look so great," and one of the things they said is like, "Yeah, I could tell you didn't get the jab." I'm like, "Well, actually, evidently I look great and did." And I had I was apprehensive about it. I'd already had a rather significant adverse reaction to it. Um, there's not really good research to let me know if I'm just predisposed to that. The I had just been, in an ICU unit with like really like the highest level of intervention that anyone could have. Like if there was a machine, it was used on me. Um, if there was a scalpel, it was used on me. And so I was really, nervous about that. But I was also like, I didn't want to go back to the ICU,
Right.
right? Like I've been there and there kind of could not be anything like in my life. I feel pretty confident saying there's really not a whole lot that is worse than that. I'm not saying there's not anything, but there's not a whole lot worse than that.
Right.
Slowly being eaten by gerbils would be pretty horrible, but I don't know if it would be worse than that. It was pretty bad.
Yeah.
And so like that was a key factor for me. Like If there's something I can do to prevent doing that, I certainly never want to be intubated again. That was horrible. I never want to be in the ICU again. That was really horrible. So I had a lot of that hesitancy. I had a lot of that anxiety of like, I've had an adverse reaction before. I really don't want to have that happen again. However, I've also been critically ill before, kind of like actively dying before. I also don't want to have that happen again. And so like, oh, my cat says hi. How do you balance those things? How do you make a decision? And it's like you just have to make a decision and figure out a course of action and think about the opportunities. And it is a risk. It is uh an uncertainty because we don't have certainties with that. But yeah, I'm okay. Like good enough to have someone be like, I can tell you didn't get that.
Nice.
Yeah. If you're watching right now, a person who said that, it's okay. I'm not upset about it. Hold on.
So, we're at 3 hours, over 3 hours. I'm out of brain juice. Quick pitch. I have this course coming out in a couple of days on long COVID. It is unlike other courses. It's the first brand new course that I've put together in years. And because long COVID is so complicated, I'm not just releasing some videos and handouts. In the course, you're going to get videos and handouts on all of the patterns, and you'll get the charts and the differentials and all of that. But also, you get 6 live classes, one on each of the patterns, to talk about the patterns, to build on the material that you'll get when the course releases. This occurs over 6 months, one a month, and you also get open case review and troubleshooting. So if you're a practitioner and you have long COVID cases and something's not working, bring them to our case review and I'll help you troubleshoot them. And you get a private forum with me and other practitioners, graduates of mine who understand this approach and work with long COVID. And so if you didn't get your questions answered tonight, you've got a forum, you've got live Q&As coming up, and lots of ways to access both more materials and my experience working with long COVID. So I hope you'll consider joining.
This is a new course?
Yeah.
You didn't do it in 2014?
I didn't do it in 2014. It's brand new.
Really? Not in 2014?
Not in 2014?
Oh.
Jim, thank you. It's been fun. It's been a good conversation. And maybe we can do this again sooner rather than later.
Right. And we didn't have to like hold our hand up and like switch ears and, like deal with ear sweat.
I miss the pacing. That's the only thing about our conversation tonight that's different. I'm normally just walking back and forth continually when we talk.
like, should we?
Oh God, then I'd get sick to my stomach. I don't think we could do that either.
No. People can see that my ceiling is not finished. Like the wall looks a lot cooler than the ceiling above the wall. The illusion is ruined.
Jim, thank you so much for tonight. Let's talk again soon. Everybody watching
thank
on
everyone
YouTube,
for coming out.
Thanks, everybody.
Have a great evening.
Bye.
Bye.